Good morning. I appreciate everyone being here. We're going to go ahead and get started. This is the House Governmental Affairs Special Subcommittee on Local Service Delivery. We appreciate everyone being here today. And this is a little different. We've been looking at services and how our citizens are receiving them and are they equitable throughout the state. During our meetings, we've come to the conclusion that there are some healthcare issues out there that are not actually delivered, have the same problems, maybe a little bit different twist in both our rural and our urban areas. So we appreciate everyone being here today to help us address those. I will share with you that we have an agenda, and it is going to begin with our county health departments. We are going to hear from Dr. Chris Ruston. We're going to then hear another section, which will be the federally qualified health centers. And our last panel discussion will be with hospitals, both large and small, so we can look at an overview. Now, this is a formal meeting. However, it will be a question and answer, a very relaxed atmosphere. We are looking to hear what your issues are so we can look for solutions to them. The health of our citizens of the state of Georgia is important to everyone, and to see that it is evenly distributed. And there's been some breaks, and we want to see if we can adjust them. Again, I appreciate everyone being here, and I'm going to start down in the first row. If each member of the committee will introduce themselves and where they represent.
Hi, I'm Jay Collins. I represent the communities of Temple, Villa Rica, and Northeast Carroll County. Currently House District 68 that's going to materialize into House District 71.
Are you on, Mary Margaret?
I'm Mary Margaret Oliver. I represent House District 82, which is in the middle of DeKalb, includes parts of Decatur, Brookhaven, and the city of Atlanta.
Chairman Rob Leverett, House District 33, soon to be 123. I represent Elbert, Lincoln, parts of Madison, parts of Wilkes, and a few precincts in Columbia counties and cities of Elberton, Lincolnton, Colbert, Comer, Carlton, and Hull. And Washington, sorry.
Good morning, Representative Victor Anderson with House District 10 that will remain House District 10. Currently representing most of Habersham and most of White counties. The new district will be almost all of Habersham County and all of Rabun County.
Thank you. I'm Representative Darlene Taylor, and I represent District 173, which is still the same. Currently, I represent Thomas, Grady, and Decatur County. With the redistricting, I will just represent Thomas and Grady County. So you can see we've got a lot of diverse areas that we represent. And if we could, I'd like to open in a moment of prayer. I will ask Representative Anderson, will you lead us in prayer?
Yes, ma'am. Let us pray. Dear kind and heavenly Father, God, we thank you, Lord, for the opportunity, God, you've given us all to live in this state, Lord, in our various regions around the state, God, that everyone is so very proud of, Lord. Dear God, we ask that you'll guide this committee. You'll guide those who come before us today. We're all leaders in our areas and our communities and in this state. We're trying to seek your will, Lord, for the people of Georgia. In Jesus' name we pray. Amen.
Thank you. All right. If we could have our first speaker come up. Let's see, Dr. Chris Ruston. Okay, help yourself to the podium. Thank you.
Hey, good morning. All right, so the presentation's on that screen, not this screen. Okay, good morning. My name is Chris Ruston. I serve as the director of the Chatham County Health Department. Today, I'm going to talk about kind of a comparison between urban and rural health department public health service delivery. All right, next slide. What I hope to get out of today and hope that I can share with you all is that what my plan is to compare Chatham County Health Department, which is a large urban county health department, to McIntosh County Health Department, which is a smaller, much more rural health department within our public health district. I'm going to talk about core public health services that are offered in all of our health departments. Again, the comparison between urban and rural health departments, and then most importantly, the capacity issues that I think impacts primarily rural health departments, but also urban health departments. Next slide. So the Georgia Department of Public Health, the best way to describe our state is a hybrid state. We have a state health department, Department of Public Health, the state office in Atlanta. Our state is divided into 18 public health districts. You can see the different colors sort of demonstrate the different regions or the different districts within our state. A district can be as small as one county, but most of those one county districts are your metro counties. They have a very large population, or they can be like the brown colored district, which is our Waycross region, can have 16 counties. Generally, population sort of dictates the size of the geographical region. Within those districts, there is a district medical director. The district health director oversees all the county health departments within a district, and those district health directors report to the public health commissioner, Dr. Kathleen Toomey. Within each district is county health departments or boards of health. There's 159 counties, so we have 159 boards of health, 159 county health departments in the state. The boards of health have statutory authority to provide oversight of the health departments, but there's a lot of cooperation and blended authority between the State Department of Public Health and the county health departments. Again, the district health director is sort of the connecting dot, providing that oversight to those county health departments with the Department of Public Health. And the goal of all of these health departments is to provide public health services to over 10.8 million citizens. And also I'd like to add visitors in our state, and I'll talk about that a little bit more. Today, we're going to talk mostly about Chatham and McIntosh County, which is located in the Coastal Health District. That's the yellow district that basically touches the coast. It's District 9-1. Next slide. So just to give you just a brief breakdown of the two different counties that I'm going to highlight here. Chatham County is a very large urban county. It's the 6th largest county in the state and has the 2nd largest city in the state. The population, at least the estimated 2022 population right now is a little over 300,000 people in Chatham County and about 150,000 in the city of Savannah. So it's about half and half. There's over 135,000 housing units. The annual per capita income is 33,000 and some change. The poverty level is around 15.6%. And I added this metric about broadband internet subscription because a lot of what we do now, it really depends on having access to internet. So about 88% of the citizens have access to broadband internet subscriptions. Comparing that just up the coast to McIntosh County, which is another health department within our public health district. There's about 10,300 people within that county, about around 6,700 housing units. The per capita income is around 28,000. About approximately 20% of the population is in poverty, and about 75% have access to or have subscriptions to broadband internet. This, from an urban versus rural perspective, this is probably a good reflection of a lot of the rural counties around the state in this type of comparison I'm going to talk about. Next slide. So these are the core public health services that really are offered in all of our health departments. We'll start off with immunizations. Most of you, if you've had children or maybe yourself have received some kind of immunization from a health department. We offer child immunizations, your typical MMRs, measles, mumps, rubella, chickenpox, and also adult immunizations, anything from shingles to COVID vaccines, for example. We offer women's health services. This includes family planning and pregnancy testing, as well as breastfeeding support. STD services, which includes testing and treatment if a STD is diagnosed. HIV services, which for some of our health departments includes walk-in testing, as well as self-test kits people can bring home. Tuberculosis services are offered through our health departments, which includes testing and treatment if diagnosed. And some health departments have the ability to do x-rays within the health department, like Chatham County. Some of the smaller health departments would contract that out, most likely to an imaging center. Children's services, these are a variety of programs that are focused on children. Children's First is really the main program that if any child at risk can be enrolled in this program, and they look for services that the health departments may not offer. Babies Can't Wait is a program that's offered to children up to 3 years of age if they are identified with any developmental delays. And that program works to make sure these children have access to various services. And then Children's Medical Services focuses on chronic disease in children, like asthma, for example, and ensuring that these kids have access to services for chronic disease. We also offer the EEDs. These are required to go into school, public schools in Georgia, ears, eyes, dental screenings, as well as lead screening. Children can be tested for lead within the health department. The breast and cervical cancer program generally partners with hospitals and other entities to offer mammograms, but we also offer pap smears and referrals based off what we find when we do those services. Our WIC program, Women, Infants, and Children's, offered in every health department. We are rapidly moving to EWIC in Georgia. For a number of years, we have been using paper vouchers, but we're moving to a debit card system. The Coastal Health District was the pilot district, and we had a successful pilot. Now individuals who qualify for WIC can get a debit card. And what that does is it allows them to manage their benefits better, but also it takes away some of the stigma of having to hand out paper vouchers when you're in line purchasing milk or cheese or eggs or other nutritional needs for a mother or baby. And then lastly, this is the one that I wanted to mention when I mentioned citizens of Georgia and visitors. Environmental health services. These are the non-clinical services, for lack of a better term, your health inspectors around the state. Environmental health services include inspections and licensure of restaurants, hotels, public swimming pools. Body art facilities are inspected and licensed. Septic tank systems, if you live in a rural area and you have to get a septic system, those are inspected and permitted by the environmental health team. They investigate cases of lead poisoning in children. They go into the homes and do investigations. Also animal bites. A lot of people don't know all animal bites in Georgia are investigated by the Board of Health. What we're looking for is to make sure that the biting animal has not been exposed to rabies, or if it's a dog or cat, that they have their rabies vaccine to protect the person bitten or another domestic animal. And then in complaints and investigations, a lot of environmental health complaints come in that we investigate. We work with a lot of agencies to try to resolve those complaints if they're not under a public health jurisdiction. These are the basic core services that you should see at every health department in the state. Next slide, please. Now, when you start comparing and contrasting kind of an urban health department that would have a lot more resources available to a more rural health department, at Chatham County Health Department specifically, in addition to those core services, Chatham County Health Department has a WIC garden. What this is a community garden that vegetables are planted year round based on the season, and clients that come in that are on WIC are able to get fresh vegetables throughout the year to ensure that they have access to that. We have in Chatham County, vital records is in the health department. Now, this is going to vary across the state. In some counties, vital records may be in the probate office. It may be at the county courthouse, but in a lot of big counties, it's in the health department. In Chatham County, vital records office is in the health department. And that's birth, death, and low THC oil cards are administered through that program. We have a laboratory in our health department, which oversees our pharmacy. We have an in-house pharmacy for the various drugs that are administered within the health department. And we also serve as a regional pharmacy for some of the smaller health departments within our health department district. We have a travel clinic at the Chatham County Health Department. If you are going on international travel, you may need vaccines for that, like yellow fever, typhoid, malaria, even rabies pre-exposure. At one point, when yellow fever was, there was a shortage of that vaccine, Chatham County was the only health department in the Southeast that had access to that. We were designated by CDC to be that travel clinic. But now that everybody, or the clinics that typically offer it, have access to it again. Women's health services, in addition to the normal women's health service, we have colposcopy, and we are able to offer pediatric primary care at Chatham County. We actually have probably one of the only pediatric nurse practitioners in the public health system in Chatham County. We're very fortunate that we was able to hire this individual. She's currently the nurse manager for the health department. We're able to offer physicals and well checks, sick visits, and we can do rapid lead testing. We have machines to be able to do rapid screening. We have a dental clinic in Chatham County at the health department. It's and primarily for underserved children who are on Medicaid or have no insurance options. We offer x-rays, cleanings, fillings, extractions, sealants, as well as fluoride treatment for these children. And we see a lot of children in our dental clinic, and the number of kids with really significant cavities is very prevalent in this population that we're serving. And so we feel strongly this is a good service that we offer to the community. We have a car seat program where we participate in the Governor's Office of Highway Safety car seat program, where if a mother or a caregiver comes to our health department and doesn't have a safe car seat, we have trained technicians and we can provide a car seat to that family before they leave. And then we have additional HIV services within the health department. We're able to offer pre-exposure prophylaxis as well as NPEP, which is emergency prophylaxis if someone is exposed within the health department. Next slide, please. The services I just mentioned would most likely not be offered in McIntosh and probably not offered in many rural counties due to primarily resources and capacity. But when you look at sort of a comparison and you kind of get back to that capacity, that access to help, Chatham has 2 large health department facilities in addition to a HIV care center that is dedicated just for that service. We have dedicated mobile clinical teams that can go out in the community, and we offer services 5 days a week throughout our health department. McIntosh County is a very small rural health department. In a lot of cases, the Coastal Health District offers staffing resources to augment their limited staff. But unfortunately, due to staffing issues within that health department, because it is a small county and a small health department, a lot of those services that I mentioned earlier are not offered 5 days a week. They're offered sometimes 1 to 2 days a week, or in some cases, 1 to 2 days a month. For example, LARCs, or long-acting reversal contraceptives, are generally only offered 1 to 2 days a month in that health department due to staffing issues. There's a lot of public transportation options in a more of a larger urban county. All of our health department sites are located on a bus route. And so a lot of our clients who don't have cars can hop on a bus. Chatham Area Transit offers dedicated bus routes as well as vans that they can pick people up. And then there's a Coastal Regional Commission service that offers vans within our region. In McIntosh and in other rural counties on the coast, the only option they would have would be that Coastal Regional Commission that offers vans. We have a variety of partners in Chatham County. We're very blessed to have those partners and the resources. We have 2 large FQHCs, J.C. Lewis Health Center, as well as Curtis V. Cooper Health Center, and a variety of community clinics that are available. So if there's services that we can't offer, we can refer those out. And we have a lot of good partnerships with our FQHCs and community centers to do that. There is one community center, one FQHC in McIntosh, the Coastal Community Health Center, that they could provide referrals to. Again, larger county, we have access to hospitals. We have 3 hospitals in Chatham, acute hospitals, as well as the Georgia Regional Mental Health Hospital, and a lot of smaller private rehabilitation hospitals. In McIntosh, there's not a hospital, and so they would have to refer folks out of the county if they needed something like that. And so our urban versus rural, you start really teasing out, it's just a resource difference that's available within those 2 counties. Next slide, please. And then if you look at, again, going back to resources, staffing is always an issue, even for urban counties. But the reason that Chatham, a large urban county, is able to offer those services, on the right side of this slide, you can see the differences in staffing. Chatham County has around 100 FTEs, which includes public health staff as well as a few contractors. And this is sort of broken out into around 48 clinical staff. We have RNs, we have advanced practice nurses, LPNs, nutritionists. We have a physician on staff, as well as a dentist. We have a customer service reps. These are when you go into a health department and you go up to one of the windows, that's a customer service rep. These individuals are checking people in, they're charting, they're putting information in the medical record. They work in our WIC clinics. We have 15 environmental health staff that does inspections in the county, and then our vital records facilities and administration. We do have vacancies in Chatham County. At one point, we had 19 clinical vacancies, and that's been a huge challenge to keep clinicians in the public health system. A lot of it has to do with salary. I think everybody that's in the health sector has struggled with keeping nurses. The travel clinics, the travel nurses are able to make a lot more money than we can afford to pay in the health department. And we have lost a lot of staff to that. We've been working diligently to get our staffing back up, but we still do have vacancies. For example, in our TB clinic, we have an X-ray technician position that's been open for 2 years. We have a dental hygienist position that's been open for close to 2 years. And we've been working to try to fill that position, but have really struggled given all of the options that are available for that profession in Savannah. We've struggled to get someone to come to the health department. When you look at McIntosh County, if you look at FTEs, they have 5 public health staff at that health department. So one vacancy is half their nursing staff. They have 2 nurses in that health department. So as you can see, with the limited number of staff, and it is a small rural county, it doesn't take many vacancies to really impact service delivery at that health department. The public health district backfills, they currently have a vacancy. And so they only have 1 RN in the health department right now. And so the public health district will backfill and send staff to the health department to assist and provide services for the citizens. They have 1 environmental health specialist in that county, and it is a large geographic county. And so, as I mentioned earlier, our challenges are recruitment, retention, especially in rural areas, but even in urban areas, we struggle with that. When you have recruitment and retention issues, the clinical capacity impacts include the types of services that can be offered. If you don't have enough nurses, you can't offer that many clinical services, or you can't offer the volume of services or the number of days that you would like to offer. On environmental health, response time for services is critical. And if you've ever built a house and you borrowed money to build a house, you know that clock's ticking on your construction loan. If you don't get your septic tank permit, you can't get your building permit. And so if 1 environmental health specialist has the entire county that they have to provide all of those services for, restaurant inspections, hotel inspections, septic system inspections, and they have islands they have to go to. They have to hop on the ferry to go to Sapelo. And so you can see very quickly that response time can be impacted very quickly in a rural county, and consider the drive time just to get to some of these locations. But so one of the probably the key things with environmental health is response time. We try to respond as quickly as we can, because pretty much everything that we touch has a financial component to it. A restaurant's trying to make money, a hotel's trying to make money. We do impact the business community, and so we do want to improve that response time, but that is challenging. And that 1 environmental health specialist, he just retired. And so they're filling in with other counties, and it's more of a part-time environmental health program right now in McIntosh because of that. And then lastly, staffing impacts emergency response. And I'm going to highlight COVID and monkeypox just to give you an idea of how limited staffing can impact that. Next slide, please. So on our COVID response, we've been responding to COVID now for over 2 years. In McIntosh County, when in the beginning of COVID, it was all about testing. There was no vaccines for the first year. And so we were asked to stand up testing sites very rapidly, very quickly. But in a small rural county, there was limited community-wide PCR testing available. They were able to offer testing, but it was on a very limited basis. Currently, we have started piloting and rolling out these testing kiosks. If you think of a red box where you can go pick up DVDs, we have a kiosk now where you can go get a test kit. We have 1 now available in McIntosh County in Darien that's available 24/7 access. And then all of our health departments are now offering over-the-counter test kits to the public if they need them. On the vaccination side in McIntosh, vaccinations are offered at the health department for COVID, but they're only offered 1 day a week right now due to the limited clinical nurses that they have on hand, and they only offer Moderna vaccine. The reason for that is Moderna is easier to store. They have made some changes to the vaccine, but in the beginning, you couldn't store Pfizer in a normal laboratory grade refrigerator. You had to have a special unit. You can store it now, but the health department chose to stick with Moderna in that particular location. And compare that to an urban county in Chatham, we are able to offer community-wide drive-through PCR testing 6 days a week. We have 2 kiosks available. We have mobile testing, at least early in the pandemic. And we also have over-the-counter test kits at all 3 of our health department sites. On the COVID vaccination front, we're able to offer vaccinations 5 days a week, and we have all the COVID vaccines that are currently on the market available. And we allow walk-up services and have mobile teams that can go out. But again, it's resource differences that allow us to do that. As I stated in the bottom of this slide, I think really the staffing challenges is what equals limited services in most cases. Next slide, please. Next slide, please. So on the monkeypox response in McIntosh, there's very limited testing available for monkeypox, again, because of the clinical having access to nurses to do that. And they currently don't offer vaccinations for monkeypox. They refer out to either Glenn County in Brunswick or Chatham County Health Department. In Chatham, we were able to offer daily medical assessment and testing by appointment. And we couple that with STD testing as well. And then on the vaccination side, we're able to offer daily vaccinations at the main health department site and 2 days a week at our other location. And then at our HIV care center, we offer monkeypox vaccines to clients that come in. Next slide. You know, when you look at county health rankings and you know, there's a lot that goes into this. The only reason that I wanted to show this slide is, you know, public health is not the end all be all help to the health outcomes in a community. There's a lot of other factors that go into that. But these two health rankings kind of give you an idea. And as you can see, the darker the colors means the poorer the health outcomes, or the poorer the health factors. And as you can see in a lot of the rural counties, and I think it goes back to having access to services, you see a lot of darker colors. McIntosh is not quite as dark as some of the other counties on health outcomes, but they are darker than Chatham. And I think it does get back to access to resources. And then on health factors, one of the things that they look at is access to clinical care. And there's certainly more access in a much larger urban county than there would be in a rural county. And I think that you could say that for most areas of the state, that larger counties will probably have more resources, a larger referral network, a larger access to FQHCs potentially in the community, or other community clinics that are available to its citizens. Next slide. So in summary, as I mentioned earlier, all the health departments in Georgia offer those same core public health services. But I think, you know, urban health departments do have more capacity. If they lose a nurse, it's not as, it's impactful. But if you have a county like McIntosh where they only have 2, and if you lose 1, that's half your workforce on the clinical side. That's where you start seeing sort of the biggest differences in access or public health service delivery. Again, staffing challenges are a problem across the board, whether it's a rural county or an urban county. I think we all face the challenges, but it's probably more impactful in a small rural county. Trying to recruit nurses, especially, or other specialized healthcare to work in those counties is very challenging. Next slide. These are some pictures of some of our sites. The large red building is the main health department, Savannah. The left building is one of our alternate sites. And then on the right is the McIntosh County Health Department. With that, I'll be happy to take any questions.
Thank you very much. We do have a question. Representative Brunel.
Thank you, Madam Chair. Thank you for your presentation. I'm sorry I was late, but I do know a little bit about this. Who all is involved in your health district? Are there other counties in your health district, or are you all standalone?
No, ma'am.
Okay.
There's all the counties on the coast, from Effingham County, which is our most northern county, all the way to the Florida line, makes up the Coastal Health District.
Okay, I live in Clayton County, and so Clayton is the largest county, and we were put into a health district, and we didn't have our own health director. And what I found was, and I don't know if this is true for you all, was that they were using our data to get the money. And so what happened was that I think I forgot the county that's down. A smaller county was in charge of us. And they were taking our resources down to there. So is that how it works there too? Do you use everybody's data, and then you keep the majority of the services, and then the rural counties do not have the services?
No, ma'am. Basically, we have a regional office. We have 2 district offices in the Coastal Health District. The large main office is in Savannah, which is where our district health director is located. And then in Glenn County, we have a smaller district office where some of the regional staff are located, or district staff are located. The funding that comes to the health department goes to the lead county, which is Glenn County in our district, actually. And then from there, each district is allocated funding based off of a formula. And the formula includes some contribution from the county government, but it also includes state contributions as well. And so it's proportional to population as well as the poverty rate within a county. And each county gets a proportion of that funding. But as far as mandated services, each county is separate. So each Board of Health is mandated in that county to provide services for that county. The district provides resources for support for us.
Well, I understand that, but like I said before, was that they were writing grants, and then the grant money would go down to the county that was designated to be in charge, but we're the largest. But we rectified that. Dr. Toomey has given us our own, so we're not going to be part of a district. But the other question I had was, what about your fire department? Does your fire department, your ambulance, do they have, we have a very innovative fire chief. So like I just left there, the headquarters is right down the street from my house. So I had to get a COVID test so I could go over there and get it. They let me get tested there. But they also have nurses that go out with EMS so that they can do that kind of care. So the person doesn't necessarily have to go into the hospital. So, and they also bought those freezers for Pfizer so they could have the Pfizer shots. So do you all work with your fire department too?
We do actually. And I don't believe that they offer that same kind of paramedicine model that you mentioned. But we work very closely with our fire department. They've helped us host COVID vaccine events. In fact, we have a standing COVID clinic 2 days a week in the downtown city of Savannah Fire Department because it's close to foot traffic. So people that need to be vaccinated can come and do that. And so we do work very closely with them. And I would consider our fire department a strong partner of ours in Savannah and probably in most of the counties, I would say, on the coast.
Okay. And then how do you all advertise to get nurses or other medical personnel?
We advertise through the state public health act system. We do health fairs with the colleges. They through social media. I mean, we offer and advertise through a variety of services. It comes down to competition. I've always felt like public health is a calling, and that a nurse has to truly want to work in community health to be satisfied. And so you just have to find the right person. Sometimes it takes longer to do that. Okay.
Are you all going to participate in the Well Stars? Well, Well Stars is going to have a job fair. Are you going to participate?
I didn't know about that.
Yeah, they are.
Yeah, Bobby.
Because they don't have enough places.
Yeah.
For their
we
doctors.
can certainly. They probably wouldn't want us to pull down to the coast, but.
Thank you.
Thank you.
Thank you very much. Representative Anderson?
Yes, thank you for the very informative presentation there. I've got a couple of questions. First of all, I noticed in your presentation that you in Chatham County, you have a WIC garden program. Right. Do you also offer the farmers market program through WIC?
We actually partner with, there's an entity in Savannah called Pharmacy, spelled with an F. It's basically a mobile farmers market that comes to our health department and offers fresh fruits and vegetables for clients who are on WIC. They come to our health department, they park. One of the things that we're trying to do is expand our partnerships with our WIC gardens. Because of COVID, they've sort of been dormant. We just brought it back about a year ago. And so there's a lot of opportunities, I think, to work with the community to try to get the word out. We've sort of kept it, I wouldn't say it a secret, but we primarily kept our vegetables for the clients that come into the health department. But our vision is that more people could come there and actually get access to those vegetables.
Okay. Do you have a dedicated staff, or is that just a function that's spread out or assigned to someone?
We have a facilities team because we have so many buildings and actually a large property that we have a facilities team, and that's one of their duties is to maintain the gardens for us. And what they do is they pick vegetables, they weigh them so we know how much produce we're providing. They put them in bags and put them in our refrigerator. And as clients come in, we're able to just hand bags of vegetables to them if they want them. Pre-COVID, we offered nutritional classes. And after the class, we would have the clients go out in the garden and pick their own vegetables. And that's what we're trying to get back to.
Okay. And just one last question, if I may, regarding the staffing shortages, particularly on the clinical side, where's the main competition you're having for that? Is it contract nursing services, other
contract nursing services?
Contract nursing.
Yes.
Okay. Thank you.
Mm-hmm.
Chairman Oliver, you have a question?
Thank you. What is the salary you are able to offer nurses?
So with the recent update of the governor's 5,000 raise, a typical nurse that comes in at entry level is probably in the mid 40s. And on the coast, we do offer some incentives. We have a bonus package. We can generally get them up to 50 pretty fast, but that is about the average salary for an entry level RN right out of college.
Is it true that the standard hospital entry salary may be closer to 60 in your area?
My understanding, yes.
WIC, as you mentioned, just went to a debit card. Georgia was the 50th out of 50 states to offer to move that new technology. Is there a reason for that? I was very
Well, what I've been told is that we started that process a few years ago, and there was a change in vendors with the technology. Then COVID hit, and it just sort of shut everything down for almost 2 years. There was some work that happened during the COVID response that most of the health departments were, or all the health departments were involved in. But it rapidly started, the work with the system rapidly started increasing last year. And so I can't speak to all the details on why there was a delay, but our goal is October 1st, every health department in Georgia will be offering EWIC services. And they've got a rapid, very aggressive plan to roll this out to all the other public health districts.
Finally, Madam Chair, if I may, I have tried in the past to try to understand of the 159 counties, what is the extent of pregnancy services women receive? In your smallest county on your coast, obviously you have a doctor there once a month, twice a month.
So the pregnancy services primarily is going to be through the Women's Health Program, and they can offer contraceptive services, pregnancy testing, long-acting reversible contraceptives, as well as IUDs. But those services are only going to be offered sporadically throughout the month because of the staffing issue. So in Chatham County, we're blessed that we have nurse practitioners on staff. We've got the ability to offer those services every day of the week.
It doesn't sound like then that you're able to offer basic prenatal care.
It's limited in the rural counties because of the staffing in most cases, at least for the McIntosh County, yes.
Thank you.
Representative Leverett.
Thank you, Madam Chairman. Thank you, Dr. Ruston, for this presentation. As Representative Anderson said, it was very detailed, and I know you put a lot of effort into it. It's very eye-opening, I think, to see the disparities, which I think you would anticipate in a larger county. You've got more people,
Right?
Kind of able to offer more services. But in one of your charts, and I was taking some notes and probably just missed the FTE. Is that the same thing in the schools? That full-time equivalent?
That's correct.
Okay.
Yes.
And on the chart you had with the map, if I'm understanding correctly, on both of them, the darker the shade of the color, the worse you are.
That's correct.
Okay. So you do see that pattern you pointed out. What do you see as potential solutions? I'm assuming they involve expenditure of money or dedication of more state funds, but is it primary to allocating more funds to staff so you can increase the staffing, just increase the staffing at these in the more rural areas?
Well, funding's obviously always needed. We have to pay the nurses. We have to pay them a competitive wage. I think that's one solution. I think working with the universities to craft, I guess, a better advertisement for our services and what we do. I mean, we offer something that, hospitals are great. They offer a great benefit package to nurses, and we certainly appreciate that. We've got to, I think, honestly, the private sector does a better job of recruitment than the public sector, quite frankly. And trying to attract young nurses, young clinical staff that want to come to the health department. We were going to have to get to them when they're in college. And we're not obviously going to recruit all nurses to come work at a health department. That's not every nurse wants to do that. But if we can pick up a few and entice them to make a career out of it, I think, especially in the small counties, having a nurse, having an environmental health specialist stay and make a career out of it to me, makes the program just more robust. because there's a lot of training that goes into training a public health nurse. They are allowed expanded authority under the district health director. And so it's a lot of training they have to go through. And we've just got to do a good job of recruiting these nurses, these clinical staff to want to work at a health department. And part of that obviously includes better salaries.
Are there any opportunities with technical schools? I know at least in Elberton, we have a satellite campus of Athens Tech, and they have a nursing program. I don't know if that's offered at every location, but is that something that would be feasible to help, or do you find the level of training sort of negates?
No, I think that, in fact, we work with technical schools. We hire a lot of LPNs. We hire 2-year RNs that go through the 2-year program. And that, there's technical schools all over the state. And I think that as part of our recruitment strategy, we've got to make sure we hit those technical schools in addition to the larger university systems, because I think a lot of the technical schools, the folks that go there tend to be local in a lot of cases, and they're more likely to stay local and want to work within the health department. So it's certainly a great idea. And I know it's something that's been discussed by the department to work closer with those technical schools.
So that's something you're already working on. So
Yes.
Sadly, I didn't just suggest an idea you'd never thought of.
It's a great idea.
Okay. Thank you. Thank you, Madam Chairman.
Thank you. Representative Maynard? It's not coming on.
Testing. Okay. Thank you for the presentation. 3 questions for you, and I'm going to try to remember them all. The first one is for the gardens, the community gardens. What is your supply and demand like? Do you have enough supply for the demand? Are you throwing away food?
No, we're not throwing away anything.
Okay.
We have a pretty strong demand for it. When we offer fresh vegetables can be expensive at times. And so we offer a variety of things, tomatoes, peppers, we've had kale, okra, we did beans this year, a variety of herbs that we have. A lot of people want those. And so the demand's been pretty high for those. If we get to a point that we look like we're going to have to throw anything away, we donate it. We donate it to our that pharmacy program, pharmacy with an F, spelled pharmacy. We certainly don't want to have any vegetables go to waste. And as a last resort, we offer it to our employees through a sort of a lottery system. But the primary goal is to get it to the clients.
Okay, thank you. And the next question is, I'm just remembering when I graduated from physical therapy school, and, you look for who pays the most money,
Right.
and the contract PRN positions definitely pay the most money, but they also don't give you insurance.
Mhm.
And so what I have found is that the people that are taking those contract positions, either they have a spouse that has insurance, or they're just young and they don't need the insurance. And so does the county have any ability to offer different pay grades, like a contract position, and the nurse understands that they won't have insurance?
No, I mean, we have different pay grades for different types of positions, but the qualifications are established by the state merit system. The health departments follow the state merit system like any other state position. And so we don't have a lot of flexibility on like minimum qualifications. If you work less than 30, I believe it's 32 hours, you don't qualify for some of those benefits. But if you are full-time, they don't have to take the insurance. I mean, that's an option that comes out of your paycheck. Because we pay a portion of our insurance benefits. There's a lot of benefits that if you choose not to pay for them, you don't have to do that. But they are offered. There's a few exceptions. The retirement system, automatically, you have to contribute to that. And a small percentage goes into a 401k. But as far as all the health benefits, dental, life insurance, those types of things, that's an optional choice.
Okay. And another question, and I don't know where we are in this matter, but I know at one point, since there was this nationwide shortage of nurses, I feel like the federal government had some funding available for nurses to go through programming for free. And is that still going on? And is Georgia tapping into that money?
So I'm not as familiar with that program. I know that there is programs through HRSA where clinicians can, if they agree to serve in an underserved area, a rural area, or an underserved community, they can have their loans forgiven after they work so many years. And that's available now to any clinician, but I'm not as familiar with specific programs that you may mention. I'll have to look into that.
Okay, and then one more question, sorry. This is more like a facilities question. So since we're trying to figure out just the efficiency of services and in rural areas, things are more spread out. And so you're needing to centralize your services, so to speak, because I know here in Atlanta, we used to have several local clinics that you could go to, and now those clinics are boarded up and abandoned. And so have you guys thought about partnering with maybe like the schools for space? And so, you know, the community can go to the local school for services instead of a health department per se. And the other thing is, I say that is because the schools have nurses there. I'm just, you know, brainstorming.
So actually in Chatham County, I can't speak to McIntosh County on this, but in Chatham County, we do partner with the schools because they have that robust nursing program, primarily on immunizations. And so we're able to offer additional clinics at the schools. For example, this past year, we offered meningococcal, which is a requirement to go into 11th grade, the booster. And we partnered with the school to offer that clinic at a school. And it was, you know, first come, first served, but it was free to any student or any family that needed to get their child vaccinated. For flu clinics, we partner with the schools. And almost all of our health departments, we do a variety of flu clinics that we offer to the schools. And those are open to the staff as well as children if the parents consent to that. And so there is some work that's going into partnering with the schools because it is a good point. That's where kids are at most of the day, and to make it as convenient as possible, we do try to partner as much as possible with the school system.
Thank you.
Thank you.
Representative Burnell?
Thank you, Madam Chair. Just two things I just wanted to ask you about. Do you partner with the high schools? Like we have a program in Clayton County where for the fire department. So if you graduate, then you will, you know, you can go on and get a job. Have you thought about doing that? Because, you know, a lot of our kids don't really know what those careers look like. So do you go in and maybe talk to them so that they, you know, that might be something that somebody hadn't thought about majoring in?
We actually do. We go to the health occupation classes. We go to some of the schools offer a chef program, and we go talk to them about food safety and potential careers. Most of the positions in the health department require a bachelor's degree as a minimum. And so we try to talk to them about like next steps. These are the things you should focus on if you're interested in a career in public health. And it, you know, we've been successful to a certain degree. We don't really track those kids like to see if they actually went through and came to work for us. But we have had, I know that we've had one student, at least in my career, that has said they remember here in the health department come talk about careers, and then they ended up going to college and came to work at a health department.
No, okay. And are you familiar with the U.S. Department of Agriculture, their loans that they're giving for if you have, as you said, in schools, if they have a garden?
I'm not
Yeah,
actually.
there's a lot of money out there. So you may want to look into
Yeah,
that.
we'll look into that. Thank you.
All right, you're welcome.
Thank you. We have one more. Chairman Collins?
Hey, thank you again for being here with us. I've got a couple of questions and they're kind of all around the place, but one of the things I wanted to ask, what is the split with your local health department when they issue a death certificate or a birth certificate? Does that money stay in that district, or does it have to go up to the state and then be drawn back down?
No, so the money stays at the location, and so we are allowed to charge a certain fee for a death or birth certificate. And so in Chatham County, because it's at the health department, that funding is retained in the health department, and basically it covers the cost of the program to operate.
Okay, because I know in some of these counties, they're generating a significant amount of, I'm a funeral director by trade, so I was just asking that
Familiar
question.
with it, yeah.
A significant amount of money. I spend a significant amount of money with the state each month, and I was just curious about that. The second thing I wanted to ask is where the WIC program is concerned. I worked in college, out of high school, in a grocery store, and I bagged groceries and ran a cash register. With the new card, is there a way to make sure that those products that people are getting are specific to the WIC
Yes.
program?
Oh, yes. It's loaded on the card. If it doesn't qualify, it will not actually allow the person to pay for it. And so the types of things that they can purchase is preloaded on the card each month. And so if there's some item that doesn't qualify, it wouldn't allow them to purchase that.
And the reason I say that is that it was always disheartening to see someone come through with a WIC voucher, pay for things off of that program, and then turn around and buy a case of beer and a carton of cigarettes right behind that.
Yeah.
And you know, my dad was the youngest of 17 kids. And so I could see a WIC program would have been very beneficial to my Granny Collins with all those kids. So I just wanted to make sure that those guardrails were in place. Another question I had for you is, in some of the rural areas where healthcare is just basically non-existent, I know that the health department is a place where folks can get some essential services. What about general medicine? I grew up in a community where we had 4 doctors. Now we have a huge hospital and healthcare in my area. Carrollton, Carroll County with Tanner is second to none. But when I was a young man, we had 4 doctors, and they also covered the emergency room at the hospital, and they practiced general medicine. I mean, if you broke your ankle, they put you in a cast. If you broke your wrist, if you needed some general surgery, they did that. And while we have made light years of progress in healthcare, in some areas we've digressed back. So what about that young man who is maybe 18 or 19 and, you know, breaks a finger, has the flu, needs some type of general medicine?
Yeah.
Are health departments throughout our state, especially in the rural areas, are they providing that level of health care with a nurse or a nurse practitioner or anything?
No, not generally.
Okay.
Most health departments don't offer primary care services. It's
Right.
mostly preventive care services. There was a couple of examples, maybe in I think the Dublin region, where they were looking at just what you said, where they were
Right.
trying to contract with physicians to offer more primary care in the health department. And you know, that's a model that certainly could be considered in the rural areas. But in general, it's not typically something you see.
And another follow-up question, if I may, is if you provided these services, I mean, in the rural areas, to me, it seems like that may be a stopgap measure for some point in time. If we could partner with our people that, you know, at the Medical College of Georgia, those kind of things, and have some kind of partnership to where, hey, we'll fund your education if you'll remain with us for a certain period of time. That was just something that's been on my mind for quite some time. Thank you for being here with us.
Yeah, thank you.
Thank you. This has been very, very informating. I do have a couple quick questions. When you're talking about preventive care, particularly, I want to understand there's no fee to anybody that comes in. You get in, you get your treatment, whatever it is. So that is the very low safety net, but that's it.
There's a sliding scale fee. And so basically we don't turn anyone away if they can't pay. We don't refuse services for lack of payment. But there is a sliding scale fee for some services based off income, because we do have individuals that come in with insurance and we bill insurance if someone has it, but they're not denied service based off that.
Okay. And I think one of the things we've learned from this, if you've seen one health department, you've seen one health department. It's going to vary by population
Absolutely.
and what can be offered.
Absolutely.
So this has been tremendously, I think, effective for us to get that bird's eye view. But you've delved into 2 that did a great comparison, and we appreciate your being here. Thank you very much.
Thank you. For
We
having me.
appreciate that.
Yeah, thank you.
All right, we now have our next group will come forward, please. The Federally Qualified Health Centers, if you would come up, and we'll begin in a moment. We have some seats up here. I'm going to ask if each one of you, as you take your seats, if you will introduce yourselves. We'll get seated first and then let everybody introduce themselves, where they're from, so we can get a good idea of the variety of where each of you represents. Okay,
All right, I'm going to start. Good
Please do.
morning,
Good morning.
Madam Chair. Thank you for this opportunity. I'm Dr. Teresa Jacobs. I'm a family medicine physician. I've been working for FQHC all of my medical life, and I absolutely love it. We'll start the slides if we can get those up, and we can get started. And I am very quickly going to give a quick overview, and then the gentleman to my left will take over from there. What you see up on the screen now is a map of all of the community health centers, or the FQHCs, that are in the state of Georgia. We have 35 sites. We are in 129 counties, and we have facilities, well over 200 of those throughout the state of Georgia. We can go to the next slide. As I stated, I'm the medical director for the Georgia Primary Care Association. It is the member organization for all federally qualified health centers here in the state of Georgia. We are designated as the PCA, or the Primary Care Association, designated by HRSA, which is an agency of the United States Department of Health and Human Services. And there's a PCA in every state across these United States. Our mission is simply to improve access to comprehensive primary health care services for all medically underserved Georgians, and to support the continued development and expansion of community-based health centers or practices throughout our wonderful state. You go to the next slide. As I stated, we have those 35 health centers. We have, on the average, we see just over 600,000 patients throughout the state of Georgia every single year. You can go on to the next slide. Community health centers, we're not free clinics, just like our counterparts, the health department. We do have a sliding fee scale that goes according to their income. We also accept all major insurances. We are not a regular doctor's office because we provide all the primary care services, along with some additional services that my colleagues will talk about. We are a consumer-driven and patient-centered organizations, meaning on our boards, over 51% of our boards are actually patients of our health centers in that community that they serve. Our health insurance, or our health services, are affordable, they're accessible, and we consider them high quality. It's an integrated model, meaning that we integrate family planning, we integrate dental, we integrate behavioral health, all into primary care, because we believe we have to take care of the patient as a whole, as well as whatever community that they come from. Many of you know that we're funded by federal grants, as well as those insurances that we take as well, Medicare and Medicaid, and we also take the uninsured. Next slide, please. And before I take my seat, and I like to say that during COVID, health centers were crucial here in the state of Georgia. Our first drive-through sites, testing sites, or the second week in March of 2020, where we had these drive-through sites all over the state of Georgia. Most of those sites saw well over 1,000 patients every single day. And now that we've progressed, all of our health centers are not only testing, but they're also treating as well. And we're also giving the vaccines and the boosters. And we're still doing that every single day, where other health centers, other doctors' offices were closing. Just a reminder that your community health centers here in the state of Georgia, the doors stayed open throughout the entire pandemic. And we're thankful and grateful and appreciative of that. At this particular time, I'm going to turn over the rest of the presentation to my fellow colleagues here sitting at the table.
Thank you. Okay, gentlemen, if you will each introduce yourselves and just tell us where you're from. We'll have to pass that mic around, but.
Yes, that's fine. I'm Dave Ringer. I'm a physician from Lake Oconee, Georgia, and I'm the CEO of Oconee Valley Healthcare, which is a FQHC located in Greensboro, but we also have offices in Baldwin County and Putnam County. So we're based out of 3 counties. We're based out, our main office is in in Greene. But what I wanted to start with was just to let y'all know that what you do does matter. And I know you know that, but I'm an example of what you actually mentioned. 35 years ago, I went to the Medical College of Georgia, and they have a rural physician scholarship program. And that is, if you go to a small town and stay 4 years, they pay for your medical school. That I'm not sure if that's still available like it was, but I've been in my town now 35 years, so it worked. I was raised in Atlanta, Georgia. I was a city boy, and I turned rural country. And so the system does work. And just to be honest with you, I dreaded coming up here today because I'm definitely a country boy. But with that being said, the other thing is, for years, I was solo practice, in a rural town. There were 3 of us in Greene County. And we opened up a rural health clinic, or got the grant later, because what we found, and it's very difficult in rural areas, and the cities will explain different. Of course, everything is different. But when I go to church and take care of somebody with Blue Cross Blue Shield, right next to them is somebody that has no money. We're all friends. As a rural physician, I can't not take care of the person that doesn't have any money. I just can't do that. In the city, you could have a city clinic and a concierge clinic and all the different things. But the rural areas, the federally qualified healthcare centers are just a beautiful mix of, we take care of the richest of the rich and the poorest of the poor. Everybody's equal. If you have Blue Cross Blue Shield, you have United, you have no money, we take care of you. We at Good Samaritan, at Oconee Valley have 8 physicians, 2 PAs, 8 nurse practitioners. We have 1 dentist, 2 hygienists, and we see about 12,000 patients are on our rolls, and about 45,000 visits a year through our offices. We recently got a mobile unit, which has just been fantastic. Opened up where we could go to the schools. You all mentioned schools. In Putnam County, we have a mobile unit that sits out in front of each school once a day, a different school each day. There are 4 schools. And again, in some rural areas, they have the schools kind of spread out. So we couldn't just have a clinic in one school. We decided to do the mobile unit. What we found out was it made a huge difference for the teachers. We didn't realize we were going for the kids, because as you all had said earlier, there are school nurses, which are great. But then if the kid gets sick, they have to call the mother or father. They take them to the doctor, try to get an appointment, take them to the doctor's office. The clinic being there, we could, easy see the child. We do telehealth, so the mom or the dad is involved in the visit, and they go back to class. Well, that's great. That's why we did it. We found out the teachers almost love it more, because they can't have to take a whole day off to go to find a doctor's office to have their routine exams and things like that. So that has worked out really well in trying to fit in. And the other providers will also tell you they're doing similar things. One big thing is we're also the hospitalist. We work with the hospital, Good Samaritan Hospital. If you've ever come to Greene County, to Lake Oconee, we're a unique area. We are one of the richest and the poorest counties in the area. We have Hancock County next to us that we also go to, that is extremely poor. Yes, ma'am. Oh, okay. And so we were blessed with Good Samaritan Hospital. St. Mary's has made all the difference in the world for that community. We were the first Hill-Burton Hospital, good old Boswell Hospital, years and years ago, and had all sorts of problems. We've seen hospitals close around us, and Good Samaritan Hospital with St. Mary's has just been a blessing that we are the hospitalists for that clinic. And as I think you also said, we're in the clinic, we're at the hospital, we set the bones, we're available 24 hours a day. It makes a huge difference. The one problem we have is transportation. It is very easy for those rich people to get there, but a mile away are super poor people that don't have transportation. Like some of the clinics in Atlanta, they have MARTA and things like that. The rural clinics have tremendous problems getting transportation to get people to and from. So one other thing we added in this past year, it's very classic of patients to go to the hospital, be treated, stay a week, go home, and not get their medicines refilled because they can't get back to the pharmacies. They can't get it. So we started a home visits, nurse practitioners that make home visits now, house calls, which has worked out very well. Where we send, once you're discharged from the hospital, we send a nurse practitioner out to your house within the week to make sure you have it and all. The FQHCs, we have our own pharmacies, 340B program. I'm sure people have heard that name. It is the most wonderful program the government has put out for patients because they can't afford some of these ridiculous medicines, the cost. And we get to provide it at a much reduced rate so they can get their medicines so they don't end up going back to the hospital. The only problem, of course, is getting them to the pharmacy to get their medicine. So we're trying to transport the medicines to their homes. One other frustrating thing in the rural areas, which we have problems with, is telehealth. Everybody loves telehealth. It is the new thing that COVID provided. And it is great to an extent, but we don't have broadband. We have a really hard time in some areas. And of course, the rich people have everything. It's great. And I'm not criticizing that. They have, so around the lake, we have plenty, but you go about a mile or so off the lake and start heading out, and these people don't have broadband. So not only can they not get to us, we can't get to them through the remote patient monitoring, which we try to do. And that is a challenge in the rural areas, which might not be as much in the cities. The last thing I wanted to bring up for our issues, which you don't think of, but you go to a small town and you need to be that one. We want to put one doctor in that small town. We can't get real estate. There is no clinic. The little towns don't have clinics. I'm trying to put an office in Putnam County right now and in the project area, and we can't get the land to build the building. And you're talking $1 million. So we've got some federal funds, but trying to make it happen is a real challenge. Trying to get the communities to understand what an advantage it would be to help through the, I've gone through the development authorities trying to say, hey, you know, this will be good for everybody. How can we fund land or give us land or reduce land through the counties and things like that so we can put a federal clinic there? Because we don't always get the grant money. They only release the grant money occasionally for each location, but we can put in a clinic and run, we get better reimbursement through Medicare, better reimbursement through Medicaid. So we can make it work, but we just have to really watch our dollars, and finding locations in some of these small towns is a real challenge. And finally, I wanted to let everybody know that finding employees is a great challenge, as y'all have already know. Dentists in this state are a hidden needle. You can't find them. It is one of our most important things is to provide primary dentistry. We can't do it. All these little kids need their teeth cleaned. They don't need fancy, you know, root canals and all that stuff. They just need general cleanings, and we can't find dentists to support that. And Medicaid is part of the problem. It doesn't pay very well for dentists, so no dentist will take it. And then we have to try to supplement it to our grants, which we're working on. And it's just very important. You think your teeth are just those white things, but they really have a lot to do with heart disease, diabetes, and a lot of other diseases. So I think primary dentistry is very important. And I'll just finish with saying that you just don't understand if you haven't seen an FQHC. It is the best form of healthcare. I was in private practice for years. It is the best form of healthcare. We get to see everybody. The physicians don't have to make decisions on money. They make decisions on what patients need. I can't say enough great about it. We just need to get them in every single county. It would make a big difference. And I'll back off from that.
You have a question, Representative Maynard? Oh.
Nine.
Okay, try 9.
Thank you. Two questions, I think it was just 2. The first one is, when you go to the home visits, are you how is that being charged? Is it all through grant money? Is it home health part A?
No, insurance companies actually pay for house calls. I actually 35 years ago did a lot of house calls. It just kind of faded away. So Medicare, Medicaid will pay for it. If they fall under the slide, I mean, we will bill them under the slide. If they have private insurance, we'll bill their private insurance, Medicare, Medicaid. So it's just like an office visit, it's just a different CPT code.
Okay, so it doesn't necessarily have to be a home health agency
Oh,
with
no,
a
no.
COA.
Yeah, that's a whole different, I mean, home healthcare agencies are great for rehabilitation and, you're discharged from the hospital, you want a nurse to come out there and help strengthen physical therapy, to come out and do services. This is just a good old Marcus Welby house call.
Okay.
And it's billed just like an office visit.
And then the other question is the FQHCs, are they privately owned and getting federal money?
Okay, they're a private nonprofit, 501c3.
Okay.
Getting grant, and we applied for grant money through HRSA.
Representative Leverett, you have a question?
Yes, Madam Chairman. So I think Representative Maynard's question may have answered one of the ones I had. So the Federal Qualified Health Center, it has to be a 501c3 entity established.
Yes.
So you can't draw out, profits from the entity. You just pay salaries and you pay costs of operating.
Exactly.
And then you receive some federal funds to give you basic operational, assistance on just your overhead and that sort of thing.
Right. We have a federal grant is designated to the FQHC for a period of time, and you have to follow certain guidelines and use it for certain required services, which actually our required services are general family medicine, dentistry, behavioral health, and that's it.
Yeah, and we're required to offer services on a sliding fee scale. We're required to have a community board. We're required to have 51% of our board to be users of the health center. So there are a series of requirements that we must follow in order to receive the federal money.
Can you use the money? I mean, you talked about locations. Can the money be used, or is there a special type of grant through that program for your plant, for your facility, so you can build something, or is it just operations?
Just operation.
Just operation. So it's just the operation. Okay. And so is a community health center a type of federally qualified, or are they the same thing, basically?
Same thing.
They're the same thing. Okay. All right. You mentioned also, I think, to follow up on Representative Maynard's question about home visit or house calls, and you had been talking about, you mentioned that in the context, or at least right prior to mentioning that feature of one of your problems is, people are able to get these services, they get prescriptions, but they can't travel to get the prescription filled. Can the home visit perform that function?
We'll
or
bring the medicines to them. Yeah.
You can take the
Yeah.
medicines. Okay,
Yes,
great.
absolutely.
And you talked about just not being able to get real estate. Is that just because of market problems, or are you sensing a lack of interest or appreciation for what you can do in some of these communities?
I think it's, there's a misunderstanding, I think, a lot of times of what an FQHC is and grant money and why should we give you, free money and not fighting against us, just kind of understanding it. I think if the governmental agencies would if you walked into a hospital right now and said FQHC, 99% of doctors would look at you cross-eyed. It's kind of been a incredible program hidden in the back for a long time. And if you want to get some hairs on the back of your head, even though I don't have any on the top, say it's a free clinic or a poor man's clinic. I mean, it's a great form of primary care, because you have to give something if you got it. I mean, we have a sliding scale minimum fee of $30. That gets everything. So, but also if you have private insurance and you're a multimillionaire, you come see us just like y'all see anybody else. We're equal services for everybody. I mean, that's just an incredible form. It's just never really been put out in the public like it should. And I think the more you understand that, hey, this can be a joint effort with county governments to bring in, there's a lot written right now about the joint effort with hospitals, trying to work with hospitals to offload some of the just stuff that comes into the emergency room that actually hurts the hospitals. It would help the FQHC and the patient because they actually get a primary care doctor instead of just, you know, an urgent care quick fix. So you're seeing that somewhere the hospitals will work with FQHCs.
When you say work with, you mean they will allow you to use part of their facility?
Maybe give you property, give you a clinic on the property or something like that.
Have you been, when you mentioned some of the lack of interest at local levels, have you approached counties about providing, some kind of building for you, and you sometimes don't get a lot of traction?
Just not understanding. Yeah.
Have you mentioned two development authorities? Have you tried to pursue that angle where you could get development authority financing, or where development authority could provide?
I mean, I hate to be cheap, but I'd like them to provide it. They want to sell it for,
Well, of course,
Lake
yeah.
Oconee property.
I understand. I wonder, though, there could be, in my view, some legal issues about whether funding a healthcare location would fall within the statutory scope of projects that a development authority, but that's an interesting issue, because that is something,
I think
if we get enough of our colleagues to agree, we could do something about it.
Yeah, the most important thing is just to understand what we are and how, I hate to sound like this, but how awesome it is.
Well, what you could offer for economic development to a small community.
Right.
Well, thank you very much for your presentation. Thank you, Madam Chair.
Thank you. We've got some more questions, but I think we might be more prudent to finish the panel discussion, and then we'll come back to questions. And I'm going to ask you to move the mic so we can get everything on the, okay. Thank you. Again, please introduce yourself.
Yes, thank you, Madam Chair and committee members. I'm Stephen Miracle, and I work at Georgia Mountains Health Medical Group, which is based in Blue Ridge, Georgia. We are, like the others here, a federally qualified health centers, and I serve as the organization's CEO. We began in 1984 as a result of local political leaders successfully receiving a grant from the state legislature to begin a clinic in what at that time was a very rural area in a town called Morganton, population 250. We now provide access to care for anyone seeking medical, dental, or behavioral health care through offices in 4 counties in North Georgia. I want to talk for a minute about our school-based health center located at Chatsworth Elementary School in Murray County. As some of you may know, Murray County is officially part of the Dalton SMSA. Yeah, the big metropolitan area of Whitfield County. Don't be fooled by that designation. The county has many characteristics similar to rural counties in our state. For example, Murray County has no public transportation. 10% of the residents live in the municipalities. In other words, 90% of the residents in the county are dispersed throughout the county. Almost 16% of the residents live in poverty. The per capita income is $23,000, which is about $10,000 less than the average in the state. The uninsured rate of those 65 and under is 22%, which is 50% higher than the state of Georgia. Teen birth rates, as an indication of health status, is 34.2 per 1,000. In the state of Georgia, that rate is 18.8. So you have a little bit of flavor of the county that we're working with. Lots of statistics. One last one for consideration. The governmental spend on health and emergency services in Murray County is $189 per capita. The federal average, I couldn't find the state average, but the federal average is $358 per capita. So there's a disparity there. It's with this background that we opened, in conjunction with Murray County School System, a school-based health center, which we call Healthy Kids. Healthy Kids is a doctor's office located in Chatsworth Elementary School. The office is open every day, every hour that the school is in session. In fact, we open before school starts and we close an hour after the school ends. It's staffed with a family nurse practitioner and a medical assistant. The office is equipped to take care of virtually every health condition we would take care of in a traditional doctor's office. Colds and flu, those kinds of things, aches and pains. There are 68 school-based health centers in Georgia. 56 of them are operated by FQHCs. When I talk about the benefits of our school-based center, I think about two people, Tina and Mrs. B. Tina is a single mom of a second grader at Chatsworth Elementary School. Tina's child, Cindy, told her teacher one day that she was feeling bad. The teacher arranged for the child to walk down the hall to see the nurse practitioner on staff at Healthy Kids Plus. Our staff called mom to obtain permission to evaluate and treat the child. Cindy was diagnosed after evaluation with a minor non-contagious condition. A prescription was sent for mom to pick up when she got off work, and the child returned to the classroom. If that child had a primary care physician, we would have sent the visit notes to her physician. Without our service, the child could have spent a lot of time staying out of class. Mom would have had to drive 45 miles to the office to pick up the child. They would have gone to the emergency room or to the doctor's office and continued to wait. All that was avoided because medical services were available at the school. Let's talk about Mrs. B. She's a teacher at the same school. Mrs. B was feeling poorly. Yeah, I'm from the country. She was feeling poorly and went to the Healthy Kids office to be checked out. The nurse practitioner evaluated her situation, took some blood, provided Mrs. B with a treatment plan, and she went back to her classroom. Without our services, Mrs. B would have had a significant amount of time off work, thus disrupting the continuity of the educational process. The school system might even have had to pay a substitute to carry Mrs. B's class while she was seeking health care. We are not atypical in that 40% of the patients seen at our health center, Healthy Kids Plus, are staff or teachers, 60% are children. Oh, by the way, our health center also provides access to counseling services, immunizations, and other healthcare services as are necessary. One last comment. The State Department of Education is currently funding 4 to 6 startup of school-based health centers across the state. They recognize the benefits of a school-based program, which include increased school attendance, assistance with enrollment and insurance coverage, access to healthcare, and support of health and supporting of health for at-risk students. We also tend to reduce emergency room visits and promote healthy practices through health education. Thank you for the opportunity to share about our health center, and I look forward to answering questions when we get to that point. Thank you.
Thank you. I think next, Dr. Brooks.
Good morning, Madam Chair and committee members. My name is Dr. Michael Brooks. I'm an internist and CEO of the Family Health Centers of Georgia. We've been around 48 years. We provide adult medicine, pediatrics, OBGYN, dentistry, optometry, behavioral health. For a large urban center, we pretty much provide some specialty services also. We have the luxury of having access to physicians who are around the area to help support our practice. We also have 2 mobile units that we use to go out in areas in Atlanta. I mean, you have medical deserts in Atlanta that most people don't even think about for a large metropolitan area. Just like in rural areas, a lot of our patients have transportation issues and they can't get to the doctor. And we use our pharmacy as a mail order pharmacy. So if we see you by telehealth, we can actually mail the prescriptions to you. So we have a mail order 340B pharmacy where you get huge discounts on your drugs that alleviates that access to getting your prescription medications. The second thing is that we are the statewide grantee for family planning. We have 30 sub-grantees around the state where we receive federal funds to provide family planning for the state of Georgia. And we've integrated family planning into pretty much FQHCs around the state because we wanted women to have access to women's services, whether it's prevention from pregnancy or if they wanted to get pregnancy. You know, as a rural area, we recognize as the family planning grantee that women have difficulties once they're pregnant getting access to care, and it leads to poor outcomes. So integrating family planning into a primary care setting, like these guys here, where you have your own physician. So if a woman is obese or she has diabetes or she has hypertension or other healthcare issues, we can get her healthy before she gets pregnant. And then while she's pregnant, we can keep her healthy so that she don't have a bad outcome when she delivers. As you know, Georgia ranks 48th in the country on women dying at childbirth, and it's getting worse. So that family planning grant has allowed us to integrate into primary care. So especially teens, we focus on teens in rural areas. You heard Stephen talk about their high teen pregnancy rate and access to contraception. So that program actually has improved outcomes since we've had it since 2014, and we're able to show data where teen pregnancy is slightly decreasing. And we're also making some inroads in making sure that we treat some of the STIs or sexually transmitted diseases. We also, because we're an urban center, collaborate with Grady Hospital. I know a lot of you know that, and the upcoming and closing Atlanta Medical Center, which is, as you know, is going to create some issues for our patients. Having only one level one trauma center is going to be a problem, but also having access to emergency care is going to be a problem. We do offer after hours, as I'm sure all of these guys do, and we offer hours on weekends to make sure our people have access to primary care. We started our first school-based health center in 1987 at Washington High, and we have 4 school-based locations right now. Probably the only one in a high school in Clayton County at North Clayton High School in the state, where we provide not only primary care and counseling and testing, but we also mentor some of the kids on careers in healthcare. So our nurse practitioner actually teaches, has a session where she talks to children about, you know, access to becoming a nurse practitioner or the healthcare field. Like all these people here and before have said, the biggest issue we have is staffing. We compete against the hospitals for staffing, and they pay a lot more. You know, someone mentioned, you know, a nurse is going to cost you $65,000 to $70,000. You know, an MA is going to cost almost $45,000 in these days. So because we're a nonprofit, because all the monies that we receive go back into care, we have high uninsured rates and high women and men who are on sliding fee scales. So those grant dollars actually support that, but they don't actually cover all our costs. So most of our costs are made up by third-party revenue, whether it's from Blue Cross Blue Shields or partnerships to do other things. And I'll finish on this note. During the COVID, we screened over 12,000 people. I think Dr. Jacobs showed a picture. That was our tent that was there. We did over 12,000 tests for COVID, and we actually vaccinated around 10,000 people. And we went into areas, partnered with the city of Atlanta to go in areas that had low vaccination rates. And we actually put our mobile units up and we vaccinated there on site. We one of the few health centers that do have the Pfizer refrigerator. That's very expensive, but allowed us access to vaccines. So we're able to vaccinate when a lot of people are running out of vaccines.
Good morning, Madam Chair. My name is R.B. Tucker. I am the CEO of South Central Primary Care. We have offices in, let's see, we got them in Atkinson, Berrien, Ben Hill, Coffee, Cook, Irwin, and Lowndes County. So as our name implies, we are South Central Georgia. We employ right at 90 employees right now, and our patient population is around 11,000. If you add all of the populations of our counties, Lowndes is the largest with 110,000, which makes it a small urban area. And the rest of the 6 counties add up to about 90,000. So that makes them real rural. We provide family medicine, pediatrics, internal medicine, women's health, psychiatric, and integrated behavioral health. And as everybody here has stated, we provide vaccines, including the COVID vaccines, us both Pfizer and Moderna. And we did testing, and we were able to remain open during the entire pandemic, sometimes wearing plastic bags for PPE in the early days, but we did our mission. And so we went our scope on testing in the different counties. So, you know, as we went where the health departments was not. And we did put up mobile clinics in small communities and got a great outpouring from these small communities getting tested. Let's see, we also contract with the State Office of Rural Health to provide primary care for migrant seasonal farm workers in Atkinson County and Coffee County. It's a unique situation down there in that there are no labor camps. So you can't just simply go to the camp and set up and see patients. You have to find them in the fields and then check them and then provide health care. So that's a population you might not see. If you ever been to Walmart on the weekend, you might see a school bus there, but most of the time you don't see them. And they are mostly here on illegally, and they really want to go home, but they're here. We all eat vegetables, and most of the time, I'd say 99% of the vegetables is picked by these individuals. So we really need them. We also provide clinical rotations for medical assistants, LPNs, nurse practitioners, PAs, and a few docs come through our OBGYN center. Some of the challenges, well, I guess success to start with is we have a great working relationship with Dormany Medical Center, which is in Ben Hill County, and also with Irwin County Hospital, which is in Irwin County. Both hospitals are on the list of being in financial trouble. About 10 years ago, we were contacted by everybody from board members to the CEO of Dormany asking if there was anything we could do to help keep their OBGYN. Would have been the last OBGYN in the area. And luckily we were able to get her on staff and start an office under our umbrella. And she has been with the organization now for 10 years. So those services were not lost by the county. In Irwin County, they went through a real financial problem at one time and was on the verge of closing. And we were able to take over a pediatrician and a nurse practitioner in order to lessen the load of the payroll on them. They were unable to actually run those offices so they could provide the service. Those are two successes that we are very proud of in collaborating with the local hospitals. We also have a good working relationship with South Georgia Medical Center, and that whenever a patient comes to their ER and they do not have a PCP, they automatically refer them to us. And so hopefully if we can become their PCP, they will get a lot better medical care. Emergency medicine is a one-shot deal, and we keep a history so we know what's going on with you. Let's see. There's probably other things I could say. Let me look here. Challenges, yes, staff is a challenge. In the past, we have to compete with Atlanta, even though we are some 3 to 4 hours away. And that's for providers. But as of late, after the pandemic, medical assistants seem to be a real issue. I'm not sure if it's the working ethic of the new generation, but I've got providers, but we need support staff. And support staff provide better service and see more people if you've got proper support staff. So that's an issue. Broadband, it's already been brought up. Same thing, telemedicine, transportation is a real issue. You would think with Lowndes County, as large as it is, we would have public transportation down there. That is not the case. transportation issues coupled with lack of broadband means you can't provide the telemedicine that could potentially help people. But the community health centers is a great, I can't speak highly. These guys up here, before, you know, they kind of like my heroes. We see everybody, regardless of their ability to pay. During orientation, I let everybody know. It's like Dr. Ringer says, we see everybody from millionaires to paupers. We don't care. If a Martian shows up out there, we're going to see him. It's all about healthcare and it's all about quality. And we keep the stats in order to find out if we're delivering quality. And so anyway, thank you for the opportunity.
Thank you. We do have quite a few questions, so we'll get to those. I do want to add that my community does have a robust FQHC, and they're doing everything y'all said. We have them in the schools, we have them serving everybody in the community. And like y'all, I will tell you, they were right there during the pandemic, and you are very appreciated. And to many of our rural communities particular, although I know you have the deserts here, there's nothing else but y'all. And you come across fully loaded and you're there for the communities. And I do appreciate that. Okay, let's see, Chairman Oliver, you have a question?
I was going to ask again about the nursing salary. You said 65,000. Gentleman from Chatham County said about 50. Travel nurses are getting more than 100. Is that correct?
Correct.
Do you think the travel nursing 100+ salary is going to continue? How can we predict what's
I know
the
that
solution may be for this issue?
Trinity owns St. Mary's and Good Samaritan Hospital, and it's a national company. And I think they have 96 hospitals. They actually they stopped. They said no more travel nurses because they were literally paying them $180 an hour to the travel nurse. And then it was about $100 an hour getting back to the nurse. Two issues come into effect there. One, your nurses leave. You can't blame them. I mean, I can't blame them to go travel. But then the ones that stay that have been there for 20 years are making the 60, 70,000 sitting next to somebody making $100 an hour. It's not good work relationships. It's tough on the hospital. So they pretty much just said, stop. Now what has happened, and I can only speak for us, if I'm in my little rural hospital emergency room seeing a patient, and I try to transfer you to Athens or Atlanta, which during COVID, everybody was on diversion, right? Beds are all full. They're still on diversion. They're still locking down. The problem is not now people in beds. It's no nurses, so they're shutting down floors. But they would rather shut down floors than pay at $180 an hour, which is not sustainable. I mean, as a business person, it's just not, doctors don't make that much. So it's been a real challenge. So we have patients waiting days sometimes in our emergency room to be transported out, just like COVID, because we can't get them to a bed in Athens or Atlanta or Augusta, which is all related to that.
It's not sustainable is the bottom line.
Not sustainable.
Thank you. Representative Boehner.
Thank you, Madam Chair. Two questions. And this is for anybody who has the mic, I guess, the closest to them. For the FQHCs, are they mandated where they can only have so many within a certain distance geographically? So can one be on 1 mile? Can they be a mile apart, or do they have to be?
Typically, these used to call it a SRA or a specific area that you had your own area, a catchment area that you took care of. HRSA tries not to fund FQHCs on top of each other because they're needed in more places. You have to go through a process even to expand in Atlanta. I'm in Atlanta, so I put another site, I have to get it approved by HRSA because I have to make sure I'm not within so many miles of another FQHC or another community-based health center. So the answer to your question is no. They try not to put them that close together because they're needed.
Right. And the other question is, given that I'm trying to figure out, you're helping the health departments with their caseload, and I'm trying to figure out, how are you able to do certain things that the health department is not able to?
Specifically,
I feel like, so one, if there's a shortage of employees, how are you guys able to find employees and the health department isn't able to find employees?
Think of us as just, I hate to say it this way, but a private doctor's office. I mean, we're a health department, I think is we're all funded differently. I mean, we actually have physicians and nurse practitioners that practice just like any personal physician, run the business just like any, but we have guidelines from HRSA that we have to follow. I think the health department comes under a whole different, their financing and all comes under a whole different set of rules, and they're not generally set up like a doctor's office.
Right. And let me just add, so health departments are primarily for prevention. Okay. At FQHCs, we are there as a primary care office, meaning that we take care of those chronic disease patients, hypertension, diabetes, heart failure. So we do some prevention as well, but we're there as a primary care office, meaning that we take care of the entire body of that patient, including their family. So different funding sources, different missions.
Okay, and so given with the Atlanta Wellstar closing and many people going to the hospital, not necessarily for emergency care services, and you mentioned before, some of you have tried to get to partner with the hospitals, maybe be on site. So with you being in the Atlanta area, have you been brought into the discussion with the closing of Atlanta Wellstar?
No.
Well, I'm on staff at Atlanta Wellstar, and I found out on the news. So I think you got a letter?
Yeah, I got an email.
Email.
That said, I'm sure you've heard by now, and I'm on staff.
So we have, as an FQHC, we've tried to work with Grantee. We've tried to work with Atlanta Medical Center to actually put a location near the hospital to kind of offload the emergency room, because about 40–50% of what shows up is really not emergencies. And they're just crowding the emergency room. But because a lot of physicians, the way they're paid, most physicians who work in an emergency room work for a group. So they have incentives, and those incentives pay them if they see more than so many people. So under their contracts, they really can't offload. If someone shows up to the emergency room, they don't want to offload them to another site. So that was the thing we were beating our head up against. I mean, we did it at South Fulton. I think one of the FQHCs tried to work with South Fulton because they have a huge center right next door, but they wouldn't send them next door. And because of that, the cost of care in those hospitals are really high.
Now, do you think they weren't sending them because they have an obligation to not turn anyone away?
Well, there are two reasons. One is financial. If you come to see us and it's not an emergency, okay, and we have a sliding fee scale, then you pay $20, $30, $40, whatever the minimum fee is. If I go to the hospital, you'll bill me.
Okay.
So some of it's financial, some of it is the service is not available when they want it, even though we have after hours. A lot of community health centers have after hours at 10 o'clock at night, and I'm on my blood pressure medicine, I can go to the emergency room and get it refilled.
One last question, and this is only because you guys mentioned if you have emergencies and you don't have facilities for the emergencies and your constituents have to go to other counties or cities to get care. And if we're closing the hospitals that are in the cities that you might transfer your patients to, I feel that it's important for you guys to be in the discussion of the hospital closings instead of out of the discussion, because honestly, if you're not, it's going to impact the entire state of Georgia, it sounds like.
Hancock County is a perfect example. Just rural hospital, Sparta. Their hospital shut down several years ago. One FQHC in that town with one nurse practitioner. About 10,000 people live in that community. One ambulance. So if you are in that, and I go to 2 nursing homes there. So I have a patient needs to be transported to another hospital because they're sick in the nursing home. That ambulance goes out. He's gone for an hour and a half. No ambulances in that county. It's appropriate to shut down some of these little small hospitals, maybe, because we have 159 counties with 159 hospitals at one point. But Florida and other states have emergency rooms that aren't attached to hospitals. You need, like you just said, some of these places need 24-hour. And I said this last night, I don't like urgent care. I like emergency rooms. An urgent care is really a poor primary care center. You know, you need a primary care doctor to take care of all your problems, not just like he said, go to the emergency room because you ran out of blood pressure medicine in the middle of the night. But if you had emergency rooms in some of these smaller counties that have swing beds, say you live in a small town, you have your heart attack, you have to go up to Athens, you go to the small town emergency room, you get treated, you go up to Athens, then you come back for 2 weeks to be rehabbed back home where your family is. What a perfect scenario. But we're just shutting down some of these hospitals and closing them up because they can't maintain 20 patients or 30 patients in there all the time. But you need that emergency room. But emergency rooms by themselves attached to the hospital, so much cost, they lose money. But there's got to be a way to figure out how to have more of that 24-hour emergency room in some of these small towns so people aren't 2 hours waiting for the ambulance to get back from transporting to pick you up from your car accident, to go back to Athens, to wait again. I mean.
Representative Burnell.
Thank you, Madam Chair, and thank you all for the work that you're doing. I live in Clayton County, and North Clayton High School is in my district, plus it's my favorite high school in Clayton County. That's where I first started when I moved there in 95. We have Southern Regional Hospital. So when we heard that the other hospital was closing, I asked my chairman and we went and met with the new CEO there, because I wanted to make sure that the people of Clayton County would continue to be served, that our EMS drivers would not be just sitting there waiting. Our EMS drivers, they have a lot of equipment on those ambulances. Like when they came to our house, they have an EKG machine, they can give an IV, so they can kind of make sure to do some things to make sure you don't go to the hospital. But the other side of it is that we have Henry Piedmont and Fayette Piedmont. And Henry Piedmont and Fayette Piedmont, I know for sure, if you don't have insurance, they're not letting you in the door. They may make you, they will stabilize you, and then they're going to send you someplace else. So therefore, with Southern Regional, and also we're in the county that houses the world's busiest airport, there's a lot that we need to figure out. And so I do agree with the health centers that are in the schools, because I know that, being a retired educator, that I would just stay. If I had a cold, I would just keep working, because eventually it's going to run through the building and then it'll be gone. But to have that doctor there, or a nurse or somebody there, then it does make a difference. I mean, if anybody's ever been to school, it takes from like September to maybe November, and you build up your immune system and you're good to go, you know. And also we keep focusing on nurses being traveling. But I had a procedure this last week, and the anesthesiologist travels. He says he spends 2 weeks here, then he goes to New York, then he goes someplace else. So it's not just the nurses. It's like you all said, it's the other extra people that people need the care for. So I don't really know what the solution is, but if you all want to come to Clayton County, you're more than welcome.
Thank you. Representative Anderson.
First comment, appreciate you guys being where you are due to retirements and other reasons. My mother's primary care physician right now is a physician at MedLink in Habersham County. So I do appreciate that. But with that, on that same note, how often are you considered competition for private practitioners? I understand that private practitioners, family practitioners, and that sort of thing is kind of a dying breed. But do you have to deal with those in your communities? As far as competition, are you viewed positively, negatively?
We're a private doctor's office in a lot of ways. And so we're competing for patients and resources and all the above with private offices in our community. More importantly, we're competing with hospitals because hospitals in the communities where we are own the private practices, right? They've bought doctor's offices. And in Fannin County, as an example, the only providers that are not owned by the hospital are our group and a group of pediatricians. And so it's pretty tough. It's pretty difficult to compete with those because hospitals have better resources, more financial strength than what we do as a nonprofit.
Okay. All right.
Can I just throw this in there?
Yes, please.
I'm gonna, we would really love to have more teaching FQHCs for residents, that's MDs and DOs. The way they got me, I did an elective as a resident at a community health center at a FQHC, and I have not left because I saw the mission, saw what they were doing, and I was sold. And so we would really love, and it's another concern of ours, if we could have some teaching FQHCs for physicians.
I forgot to mention that. I'm glad you said that. We actually, St. Mary's in Athens started a residency program, like you're trying to get residency programs throughout. And we have a working relationship with them where we have a third-year resident come down and work at the rural hospital. My argument there was for years when I would call the hospital to transfer a patient to Atlanta, or to Athens, they would tell me, what floor do you want me to call back on? I'd say and the docs didn't understand. They didn't have a clue because it's not their fault. You're trained in the big hospitals. You're trained in the big medical center in Augusta or in Atlanta, and you don't realize these small hospitals. You don't even know what an FQHC is, as I said earlier. But so we push for a rural rotation, and it has been fantastic. We've gotten 2 doctors to stay after they've worked that one. They realize this is fun. You get to do stuff. People know who you are. As my kids say, I can't go anywhere without somebody saying, "Hey, Dr. Ringer," at any grocery store anywhere. So that's worked real well. We're also working with MCG now. Dr. Hobbs, they're wanting to put medical students back in FQHCs. They've realized that it is good to get them trained in the FQHC. So, and then last, if you're family doc trained at Emory in Atlanta, you're not going to go out to South Georgia. You're not going to come down to Sparta or Greene County. You're scared. I mean, when I'm in the emergency room at our hospital, I'm it. There's no doctor in the county. There's no specialist. There's no referrals. So those doctors are used to just referring out. So to get these people trained in the rural areas, we're starting to talk about, hopefully we're going to get some funding for a fellowship, a 1-year family practice fellowship, where after they finish their residency, they come do 1 year down at that hospital and see what it's like with that comfort level that we're there supporting them. So we're working with it, and it's really important because we need to keep them home.
Okay, one last question, if I may, Madam Chair. How many FQHC facilities have in-house pharmacies?
We have one.
Majority.
The majority of them do.
Okay.
We have just a handful that don't have in-house pharmacies.
Okay. Thank you.
Chairman Collins.
In this presentation, did you have a list of all of the facilities that you have in the state?
Yes, that map that we showed,
Right.
and we'll be able to pass that map out.
Yeah,
And
this,
you'll
this,
see,
this map here.
yes, you'll see every county that we're located in, and you'll also see the name of the health center or the FQHC that's located there. You can't see it, so you need a bigger copy of it. We'll have those for you.
I couldn't see this when I was 21.
Sorry, we'll make sure you get a big copy.
But one of the other questions, if I may, Madam Chair, and I'd hate to use the word competition because where healthcare is concerned,
It's there.
it is what it is. But say, for instance, where you have an area or region in the state, and I don't want to be too specific on this, but they have a thriving hospital, and then they start buying up all the primary care physicians. And that's great and wonderful. But it does present some problems where healthcare is concerned because you don't have a choice. There are a lot of communities where, years ago you had a lot of private practices, and then bam, all of a sudden it's 2022. And wherever you go, that doctor's office is affiliated with that hospital. And so I was just kind of wondering, have you ever, any of you gentlemen ever really tried to get in and compete in that area? I see a situation in an area to where healthcare is provided, but if given a choice, I think people would go to one of these types of facilities to get treatment. And I was just wondering if you've ever experienced that. Go into a facility that's already served, but maybe this is a niche market for your type of practice.
As Dr. Brooks indicated, for us to move into a new market, if you will, we basically require federal government approval to do that. And that approval comes based on a definition or identifying the need in that community. And that need is specific to the underserved population, right? So if all of those things match, then we would be able to secure the resources from the federal government to open an office there. So that's how we would move into a market that you described. Does that address the question?
Completely clear.
Okay.
Right on the
And let me add one more point to that.
Yes.
There are not too many other entities that are competing for uninsured patients.
Or Medicaid.
Or
patients.
Medicaid
Yeah,
now.
Medicaid is-
Yeah, right. So there are a number, I have some colleagues that are in private practice now. They no longer accept Medicaid.
Right.
So there's not competition when it comes to Medicaid patient and uninsured patient, not like you would think.
And and if I may, the reason that you're talking about in a small town, you see people in your grocery store, in your community. And I come from a community where that has happened. We had that small town feel, and now it's, big conglomerate has come in or developed, I guess I should say. So, you don't have that same kind of personal connection. There are very few physicians that aren't tied to that facility. And I miss that. I miss that relationship. And quite frankly, I had a physician that I went to for a while, and he was not affiliated with that. And he served a demographic of people that some of those other doctors did not really serve, didn't want to serve. And since he has passed, our community has lost that. And I was just curious as to what type of area you were looking at.
The Lake Oconee is a perfect example of that, because we have a lot of people with money that have come to the area. I've been there when there was just 2 docs in the whole county, and now there are several docs in the county, but they're not competition to us because they are concierge docs. And they, also the other irony is a lot of those retired people have Medicare. Well, that's another one. A lot of private docs now don't want to take Medicare or Medicaid. Medicare is almost indigent, which is kind of ironic when you have a $2 million home and you have Medicare and the doc doesn't want to see you. So you have concierge, and then we fill that gap because we take care of everybody. We love Medicare and Medicaid, except for dental.
Representative Leverett.
So I wanted to follow up just quickly, make sure I understand the sort of distinction Representative Maynard started exploring is the difference between a federally qualified health center and a health department. The health department, my understanding is it's owned and operated by the state. It's not owned and operated by a private entity.
Sure.
It receives funding, I would assume, if not exclusively, almost primarily from the state. I'm sure there's some federal dollars in that too, but it's coming through the state would be my understanding. Whereas you're a nonprofit entity, meaning you form under the Georgia Nonprofit Code probably, and you qualify as a tax exempt entity, but you are privately held. You receive federal monies, but you have to comply with certain conditions and do some heavy lifting, I would assume, that isn't considered to be terribly lucrative in order to receive that federal money. You've talked about also having doctors on staff. Is that, I guess, two questions. Is that the norm? And two, is the doctor usually an employee of the health center, or do you have some arrangement with them of a nature where, you know, they keep a certain amount of what they kill and for the rest of you?
They have to be employed. We also are under federal tort, which means basically we have no malpractice. We don't have to pay for malpractice. We get federal malpractice coverage, which is a huge incentive, not only for the practice, and that money goes back into taking care of patients, also for the physician, because if you sue me, I'll see the United States of America versus will be in the courtroom, which is a great asset. But because of that, you'd be surprised when people tell you we're the free clinic. You think, they're probably no good. No, we have to meet higher quality standards than any private doctor ever has to, because they come into our office and check everything because they're giving us free malpractice. But all the providers have to be employed under that system to get that. And we do have, just like anything else, there's, one doctor for every 4 nurse practitioners, 1 doctor for every 2 PAs in this state. So
you still comply with that sort of that leverage.
I'd just like to point out also, we have to go through a financial audit every year. In our case, it's a single audit. And then every 3 years, we have what's called a operational site visit. And in that, they come down and they basically audit us clinically. They offered our board as far as our governments is in line. And they also, again, audit us financially. So the government oversight is strong. And when we get a grant, the grant has to be used for what the grant was intended, and it's checked.
It's restricted funds.
That's correct.
And it sounds like you to establish a FQHC, if I'm remembering the anagram correctly, you have to go through something that at least conceptually, loosely sounds like a certificate of need kind of process. We have to show there's a need in a particular area that's not already being met or served by either another FQHC or other sources. Is that correct?
Correct. And there's only so much time. It's not every year that there is funds available to open up a new one. The federal government releases every now and then. There'll be, $20 million to set up so everybody applies for, and then they establish it based on need for the whole country.
And I just one final question, Madam Chairman, if I may. I think Dr. Ring, you touched on the concept of an emergency room in the context of talking about Florida. So is that a program they've set up where they either fund or establish what is a facility that's just largely, I guess, an intake and a number of rooms, like an emergency room, if you severed it from the hospital, and it operates as an independent?
That's my understanding. Yeah. But the hospital people would probably be able to tell you more than but I do know they have independent hospitals where our CON laws won't allow you to have an independent emergency room without beds and all the other things. Vice versa. You can't have, because I know when I was part of the hospital board, you can't shut down the emergency room, loses money. You can't shut down the emergency room and just keep beds. There's some red tape and all that.
Thank you.
And I'll add, the sites have to be fully operational, as well as there are clinical standards that we have to meet. We cannot not take care of diabetics, have poor outcomes. They're looking at the clinical outcomes when it comes to diabetics, hypertension, whether we're taking care of HIV patients, the whole scope. So we have to meet a higher standard of care than most private doctors' offices, even when it comes to the diseases.
Thank you. Representative Maynard, this is our last question.
Thank you. My question is, you guys mentioned a lot about the hospitals referring to their own private clinics, or not private clinics, but to their own clinics. And I'm assuming since they're doing that, it's not related to the kickback law or something. Like, how does that work? And maybe the hospitals can answer
Yeah,
that
because they have
question.
employed
They are.
physicians. Yeah.
Okay, so I'll ask them that question. The other one is for the Medicaid. And you're right, providers are not taking Medicaid because of how much Medicaid is providing for the services. And, I've really been trying to figure out, if we were to expand Medicaid, what does that mean if providers are not going to accept the Medicaid? Have you guys, as an organization, touched on that subject? I mean, because you guys are the ones that are accepting it, but you don't have the capacity, I'm assuming, to, if we expanded Medicaid, to even offer.
We will figure out how to make it work.
Absolutely.
Yeah, and I, yeah, I say that, we joke about it. But you can look at the example of the pandemic where we figured out how to make it work. Health centers across the state were open, seeing patients, taking care of people during the pandemic. Many private offices were not. We have culturally, our DNA is to figure out how to take care of people. And so I personally am a strong supporter of expansion of Medicaid. I think we all are. We would figure out how to have the capacity, if we don't have it, to make it work. We are required to accept all Medicaid patients and all Medicare patients and people who are uninsured. So that's just the way we operate. No, we're not in every county in the state, but I'm sure that if there's a need for a health center in Union County, where there's not one currently, that's a contiguous county to me. I would figure out how to put a nurse practitioner over there to take care of the expansion.
Okay, thank you.
This has been very enlightening. We appreciate all this wonderful information. I will share with the committee that just about every year in our budget, we have added something to help set up. It doesn't pay all of it, but something to help set up our FQHCs, and they have been expanding. They are a vital part of the delivery of healthcare in our state, and we appreciate your time today. Thank you so much for helping us. Thank you. Now, we're going to take a quick 5-minute break, and our hospitals will come up next. We've saved the big group for last, and I'm sure we've got a lot of good information coming. So we'll be reconvening in about 5 minutes. Okay, if we could please come back to order, I'd appreciate that. And if we could please get our hospital folks to come up to the, you want to sit as a panel? You want to each just, yeah, come on up and there we go. And I'm going to ask you, before we start, let's each one of you pass the mic and say who you are, and then we'll start with each one of you as you want to talk about your facility and your story. And you've heard a lot this morning, so you may have a few comments on some of the things you've said or have been said. And I do welcome you and appreciate very much you being here. This is an important issue. And as we've already heard, it's everywhere in Georgia. It's not just one place. So if you would go ahead and get started, you want to start, Julie, introduce yourself and.
Thank you. Good morning, Madam Chair, members of the committee. My name is Julie Wyndham. I am the Vice President of Government Relations for Atrium Health. Atrium Health is actually one of the largest not-for-profit health systems in Southeast Georgia. We are headquartered in Charlotte, North Carolina, but we have hospitals throughout North Carolina, South Carolina, Georgia, and Alabama. So I'm here today to talk to you a little bit about what our hospitals here in Georgia have been experiencing. Our main campuses are in Rome, Georgia at Floyd Medical Center, and in Macon at the Medical Center Navicent Health. But we are somewhat unique as urban hospitals in those areas in that we are totally surrounded by rural counties. So the work we're doing with our rural counties is very important as well. But as far as kind of, would you like everybody else to introduce before I jump into my comments? Okay, go ahead. Yes.
I'm Steve Watley. I'm the chairman of the Hospital Authority of Randolph County.
Hi, Robin Rao, CEO of the Hospital Authority of Miller County.
Jamie Womack, Vice President, Critical Access Post-Acute Services for Archbald Medical Center.
Thank you. And I know you were kind of looking at some of the issues that rural and urban counties are facing. For our urban centers, I'll just talk a lot about what y'all have discussed already, but we at our urban centers are have a 100% census on most days, and census just means bodies in beds. So we are full on a regular basis. That's why we rely very heavily on our rural partners to help us alleviate some of that overcrowding. Our crowding in our emergency departments is a big issue, particularly with behavioral health patients, some of whom will be in our EDs for hundreds of days because there is no placement for patients. You can usually find placement for patients who are paying patients, but if they are uninsured or on Medicaid, it is often very hard to get those those behavioral health patients out of our ED. I will mention the need. We at the Medical Center Navicent Health in Macon actually just rebuilt our children's hospital right before COVID. And at that time, we added a specific psych room for behavioral health patients. It has to meet very strict standards so that there aren't things that the patient can hurt themselves or workers with. We are already looking at having to expand that one room to 4 rooms. And this building was just completed in 2019. So just to give you a sense of the need for behavioral health care in both adults and pediatric patients. One of the big issues we face in both Floyd and Navicent is our payer mix. And these guys will speak to this as well. Our payer mix is private insurance is around 28%. So about a third of our business has to support, less than a third of our business has to support the losses in the other part of our business. We do Medicare around 47, 45%, Medicaid around 15 to 17%, and self-pay, which means indigent, around 8% to 10% at those facilities. So really, we're looking at less than a third of our business trying to support the other 2/3 of our business. So that's a big issue. Uncompensated care at Navicent in 2019 was $126 million. At Floyd, it was $106 million. One of our biggest issues that has developed was an issue that was developing before, but has been exacerbated through the pandemic is, of course, workforce. To give you an example, Atrium Health Navicin is 637 beds. We are actually the second largest hospital in the state behind Grantee as far as number of beds at one location. But during the height of the pandemic, even into this year, we averaged between 90 to 120 beds closed a day because of staffing. We just can't staff those beds safely, even at a large facility like ours. We're around 20% probably open vacancies for nursing. At some of our rural hospitals, that number goes up to 36% where they are low on staff. And that is including using traveling nurses to fill some of those holes. That is in addition to what we are doing with traveling nurses. For instance, at our hospitals, our average salary for a nurse, this is not starting, this is average, was around $65 before the pandemic. It went up to $130 during the pandemic when we were having to pay traveling nurses. And unfortunately, you can't fault the nurse because that is good pay for those nurses. But unfortunately, a lot of that money is leaving the system and going to that agency that employs that nurse, not to the nurse, not to the hospital to help with care. It's going to an outside agency. You've talked about some solutions, so I don't want to be all doom and gloom. Some of the things we've done, the workforce issue is virtual care. One of the reasons we actually joined with Atrium Health is they are one of the nation's leading providers of virtual care. And I want to brag on you guys for just a minute. Y'all have done great in this state supporting telehealth through the laws that you have passed over the last few years. Not only telehealth, but our interstate licensure compacts that you have passed for physicians and nurses and psychiatrists and all that has been a tremendous help in helping some of those workforce issues. If I could just get my folks in North Carolina and South Carolina to pass those laws, we would have way more practitioners that we could use here in Georgia through the Atrium network. Another thing we're doing, and this is something that you may not have heard about before, is using community health workers to keep people out of the hospital. This is a somewhat new program here in the Southeast. Grady's using it, Choa's using it, we've started using it, where we actually go into the community, and it's key to get people that are in the community, not clinicians from the hospital, but getting students who perhaps are interested in a healthcare career and having them go and knock on the doors of patients to do the follow-up care. They're not clinically trained necessarily. We do some basic training with them, but they just go in and say, have you taken your medicine? They look around in the house and see if there's something in the house that's contributing to the issues that the patient's having medically. And that has been a big help in keeping some patients out of the hospital. So that's something we're trying to do. Overall solutions to our issues, again, virtual help. And then there on the sheet of paper you have in front of you, I've listed a number of the partnerships that we have with hospitals around us and with the counties around us that may not have hospitals. You talked about freestanding EDs earlier. We actually tomorrow will be breaking ground on a freestanding ED in Chatham County. That county has had no hospital for decades. So this will be a new way for them to get access to care. There are some issues with freestanding emergency departments in areas where hospitals already exist and they siphon off some patients. But in areas where there is no care, it's a solution that we are trying in Chatham County. And then in the Macon area, we've assumed ownership of some hospitals there. A lot of times people think large hospitals just want to gobble up small hospitals. That is not the case. We actually need those small hospitals to keep patients that are less acute in their area and to send them back to that area once they've got the tertiary services that we provide at a trauma and teaching hospital like Atrium Health Navicin and Atrium Health Floyd. So we really see it as a partnership. If we can keep a patient local, that is better for them, that is better for the system as a whole, that is better for our facility so that we can treat the patients that truly need the services that we provide at our tertiary hospitals. And one thing I want to brag on, Peach County, we actually have a medical center there, and just the beginning of this school year, they actually opened up a virtual health clinic at Peach County. We were already doing that in our larger counties, but we're now spreading it to our rural counties. And they have already seen that they are keeping students and teachers at the school where they need to be rather than having to go and get their medical care. So that's just some of the things I wanted to highlight there. Happy to answer any questions, Madam Chair.
We're going to try to hold the questions to the end.
Okay, thank you. So good morning. I'm going to go a little bit ahead of Mr. Watley here because I think his story needs to kind of follow mine and our relationship together in healthcare. So again, my name is Robin Rao. I'm the CEO at the Hospital Authority of Miller County. As you can tell, I'm not originally from Georgia, so we're going to get that out of the way now. I'm originally from Rhode Island, but been down here for 30 years. Relocated to Georgia about 30 years ago, came on board with the Archbold organization, which is primarily located in Thomas County, but it has several had several critical access hospitals at that time, still does have some. But that was my introduction to healthcare in Georgia, was with the Archbold organization. I took a position at Miller County Hospital 13, almost 14 years ago today, when the hospital was just about closing. In fact, the hospital authority asked me to close the facility. It had, at that point in time, about 150 employees working for it, was a 25-bed critical access hospital, had a rural health clinic that functioned not really even as a clinic, and had an attached 97-bed nursing facility that at that point in time, the nursing staff wasn't willing or able to accept difficult patients. In truth, the nursing staff in that home couldn't start an IV on somebody, wouldn't accept a patient with the G tube. The hospital, maybe out of the 25 beds, they maybe had 8 patients in their average daily census. It had less than $100,000 cash in the bank, had borrowed money repeatedly over several years to pay payroll, to buy pharmaceuticals, to buy lab reagents, things of that nature. Just a horrible, horrible picture, and not much of a future as many people saw it. Today, I would encourage all of you to take a drive to Colquitt, Miller County, and take a look at what I oftentimes refer to as the phoenix that arose out of nothing. It is truly something to behold. Today, our hospital, like Atrium's, is full every single day of the year. Our 97-bed skilled nursing facility is now a 157-bed nursing facility. We own another nursing home in Calhoun County that we acquired when the Calhoun County Hospital closed. We opened up another rural health clinic in Arlington, which is also Calhoun County. We have home health, home infusion, and another rural health clinic in Miller County. We have 2 mobile health clinics that go out to some of the poorest counties in the area, out to Willacoochee, the other side of the state. And we own retail pharmacies, one right now, but in contract with 13 others, and another one that we're soon to build. So we've become a real diverse organization. We are still the hospital authority, have not reorganized. We are a not-for-profit organization, and we go where we are invited. In addition to the hospital that we own and operate, we also manage patients in Homerville, Georgia, and in Washington County, and are looking at helping out the hospital in Jefferson County. So how do we do all of that? So we started in 2009 is when I came on board with the hospital, and we started shortly after that, walking down a pathway to take care of patients that were medically needy and absolutely uninsured. And many of those patients that helped transition the hospital came from this area. They came from Grady, they came from Emory, they came from the neighborhoods around here. Homeless, medically needy people that needed health care, needed a roof over their head, but they were absolutely, you know, as I would refer to them then, and I still call them today, life's castaways. I had a nursing home that had a whole bunch of beds and a facility that need to transition. I refused to close our hospital or our nursing home for a host of reasons, but had an idea of what I could do with it, which, by the way, I offered to the Archbold organization. They didn't take me up on my offer back then. So I took it to Miller County, and here we are today. So we entertained the idea and partnered with Grady and Emory back then to help them take on board their patients that had no place to go. In the wintertime, you can just, you all see it. You drive up 75, look under the underpasses. Those people all have, if not behavioral health issues, they also, in addition to that, have medical conditions that require ongoing medical care. I had a nursing home, skilled nursing facility that was capable of providing them with an address that is all that was necessary for them to become eligible for Medicaid. So we provided these individuals that were willing to come with an address, took care of their medical needs, many of whom were respiratory patients. Many of them had trachs back then. And that started us on our journey for our respiratory care program. That program led us then to what we have today is a 100-bed ventilator program. Actually, it's a 100-bed ventilator and dialysis program in Miller County. So we have kind of morphed into really a specialty hospital almost, or a specialty organization. And all of the services that we provide in our organization have evolved around those kinds of needy patients, the care that they absolutely need. Now, obviously, this didn't happen overnight, but it happened pretty darn quickly. But the biggest thing, people know Miller County for that book of work that we do, because it is kind of, it's in your face. We get patients from all over the state of Georgia coming into our hospital, but the real bullet that saved us back then was our population health care that we started in 2009. Now, you heard the FQHCs talk about what it is that they do, but Miller County took on that same book of work as a hospital. In 2009, when nobody even heard the word population health management, Miller County Hospital endeavored to go down that path, and we did it really well. The year that I started, our fiscal year ends on June 30th. Fiscal year 2008, Miller County Hospital lost $1.7 million. That was classic for them. I started 5 days later on July 5th, entering into a new fiscal year, and we brought that loss down to $750,000. And we did that by providing case management and population health to the general public, trying to manage their congestive heart failure, their asthma, their diabetes, their hypertension, and keep them out of an emergency room. But at the same time, reinvesting in primary care so that they had a place to go to. We provided individuals with, got a retail pharmacy license, provided individuals with 340B. And yes, Miller County Hospital, like your FQHCs, also do home visits. We do community paramedicine, home visits, free, all day long, free healthcare in either of our 2 rural health clinics that we operate in, and also provide home health. All of that was our population health initiative, and is what turned the corner for our organization and provided me with the resources to reinvest in all the other programs that we've got. That kind of is like our trajectory. We've been very successful. That year was the only year that Miller County Hospital lost money. We have been successful ever since, and we pay it forward. We reinvest all of our money back into patient care and have reinvested a lot of our money in other rural hospitals who are not owned or operated by a larger organization, but independent other rural hospitals that are out there who are kind of dying on the vine. Homerville was one, Wilkes Memorial was another one, and Jefferson may or may not become a third. Now we're talking to, and I asked you to entertain Steve Watley today. We're entertaining a new project with the Hospital Authority of Randolph County with the provision, I will say, Miller County has no interest in owning or managing, will help and provide resources. But I'm going to hand it over to Steve to talk a little bit about what he's trying to accomplish in his community.
Thank you, Robin. Madam Chairman, committee members, just to give y'all a little bit of history. I came on the board of Randolph County Hospital Authority in 1994. So I've been on the board for 28 years. And during that period of time, I also served as mayor of Cuthbert for 16 years. You wear a lot of hats in a small town. Y'all all know that. Randolph County was particularly hit hard by NAFTA in the 80s and 90s and almost decimated our industrial base. And along with it went our commercial insurance for hospitals. So that left our hospital with Medicare, Medicaid, and self-pay. And self-pay is another acronym for indigent and charity. We were writing off 67 cents of every dollar that we charged. We were the first critical access hospital in Georgia, and that helped to save us for a few years. Also, the Georgia Gold program for hospitals, when they changed the methodology of that for where the undesignated funds, they changed that methodology, and it basically left us with no help on that. So when you're working hard to keep a facility open, to keep the lights on and make payroll, you have no choice except to neglect or not reinvest in the physical plant. We had a managerial contract with Phoebe Putney for 23 years. Phoebe did an assessment on our hospital 3 years ago, and the estimate was around $10 million that we needed to spend on our facility to get it back up to acceptable standards. We went to several banks, and you can imagine the greeting we got at those banks with a facility that was not making money, and we were trying to borrow $10 million. Phoebe was not interested in being involved in a facility that was substandard, so we did check around at other institutions to see if we could do a contract, not Miller County. We found no interest. So then along came COVID. About this time when we were really, really struggling, and it got into our nursing home, and we lost 12 patients to COVID, and many more contracted it that survived. Many of our staff caught it, and at that point we made the difficult gut-wrenching decision that we had to close our hospital. We didn't have the staff to run it. We didn't have the money to run it. So we leased out the nursing home, sold the medical practice to Federal Qualified Health Center. This devastated our community. And some of the byproducts of doing this were, it put a ton of pressure on our EMS. And one of the gentlemen up before us spoke about all of our EMS calls now that require hospitalization or emergency room or long distance calls. It takes 2 hours, sometimes 3 hours. So we had one fully staffed ambulance. So in the meantime, unfortunately, people have died in our county waiting on an ambulance because we signed a mutual aid agreement with other counties, but sometimes it'll take 2 hours to get an ambulance, and you know, when 5 minutes is critical, 2 hours is deadly. So that point has devastated our county. Also, the gentleman mentioned about the emergency room, about a freestanding emergency room. And you mentioned about a freestanding emergency room. Nobody wants to put up a freestanding emergency room where primarily your payer mix is Medicare, Medicaid, or self-pay. That would be wonderful if we had an emergency room. And through talking with Robin and the model that she's come up with is we can't make it with a freestanding emergency room. That's what we need. That's what our county needs. That's what Randolph County needs, and also several surrounding counties need. We were a hub for these other counties. But there is hope, we think, today. We're applying for a USDA loan, and $25 million USDA loan to build a new emergency EMR and to have a 5-bed hospital that will be at some point with the help of Miller County to help us manage it. And she is going to try to divert some of those patients, those long-term patients, to us to help us keep some of those beds full. So we are optimistic about the future. However, these things take time. The USDA loan could conceivably take 18 months and then another 2 years to raise the facility that's there now and rebuild this new facility. So I'm really concerned about our constituents and our patients during this period of time when we're trying to make these very important changes. So I guess we're here to ask what y'all could do for us. You could loan us $25 million and we get this behind us. We could get started real quickly. But it seems that the loss of the hospital was very hurtful. There's no doubt. But the biggest loss to us was the emergency room, and the pressure it puts on your EMS. And these small counties can't staff many ambulances. We can just staff one ambulance 24 hours, and it just puts us in a bad situation with having our emergency room 40 miles away. So there's got to be some planning in the future for some type of freestanding emergency room for these small rural communities that can cash flow and sustain itself somehow, because now it can't do it. You could build the nicest one in the world, and if you can't cash flow it, it's not any good. You can't staff it. So that would be, my request to y'all is to somehow look at that situation and change whatever the methodology is for those freestanding emergency rooms to sustain themselves somehow. So I'll start with that and pass it on.
Thank you, Rob. Thank you, Madam Chair and committee, for having us. You asked about issues and problems that we're having. First of all, my name is Jamie Womack. I'm the Vice President of Critical Access Hospitals and Post-Acute Services for John D. Archibald. I cut my teeth in long-term care back in 2005, worked for 6-7 years before having the opportunity to come and work for Archibald. Started my career there in 2011. And like I said, now I'm a VP of Critical Access Hospitals and Post-Acute Services. So number one problem, obviously it's been brought up, and not to beat a dead horse, but it is staffing. Not only nurses, nurse aides, medical assistants, lab staff, MDs, that's just to name a few. And what we are experiencing appears to be a lack of being produced. There's just not enough coming out to fill the holes that we have. And this has been talked about as well, but EMS, just like Mr. Watley said, is crucial to a community. And without it, with the lack of paramedics, we are very appreciative that some rules have changed so that EMTs could transport people when before everybody had a paramedic on every ambulance. Now we don't have that. There is a huge shortage in paramedics, and that is a desperate need as well. We have 2 acute hospitals, psych hospital, 3 nursing homes, and 2 critical access hospitals. So another issue for us is designation. We do have a meeting coming up with a consultant group to discuss the rural emergency hospital designation for one of our critical access hospitals to see if that is an option to make that hospital more viable. for the community. Another issue we run into is authorizations from the payers. We've seen a huge uptick since COVID with the amount of referrals being sent out for an inpatient status, and we're being told that they only meet OBS criteria. We've heard conversations with the GHA board for rural hospitals that there was an internal medicine physician who was trying to get a patient admitted. Patient was extremely sick. It got denied, put in OBS. The physician wrote huge amount of notes appealing this decision. It got denied again. So this physician refused to give up. He continued to call and request to speak directly to that physician that denied the inpatient appeal. When the physician asked, I finally called him back, he said, "Did you even read my notes?" And he said, "No, sir, I didn't." And he said, "Well, why not?" And he said, "Well, I'm a retired ophthalmologist." So something that we would like to see is there a way that when these payers are reviewing these, just as we cannot discharge to a lower level of care, it's a violation of EMTALA, shouldn't that physician that's reviewing that case be of that same level? So that is one thing I would like to bring forward to this group. The other piece of it is when we're discharging out of an acute hospital to a nursing home, critical access, swing bed, they have to apply for a prior authorization to get that, to be able to admit. Those authorizations can take several days. That's somebody who's already medically stable, sitting in an acute bed, who cannot be transferred and therefore takes up another bed for another day or two. And as Mr. Watley said, 5 hours or 2 hours can be devastating. Sitting in a bed, taking up a bed for somebody sitting in the ER is devastating as well. And I'll open that up to questions. Thank you.
I'm going to ask you, keep the mic, to share. Archibald is my home hospital, and what they did 40 years ago, several things that have been said today that we've learned. One of them, how is this got to do with local government? The hospital is the foundation of communities. And you mentioned when you lost with the loss of jobs, the same thing happened in like the, I don't know, 2008, 2010, when they had a recession. I saw so many communities actually lost the revenue. They lost the jobs. You lost the insurance. If you had anybody that could pay anything, you were lucky if they have Medicaid. That had a devastating impact on a hospitals, particularly the rurals, where you had those jobs just disappear overnight and there were nothing to supplement them or replace them. And I think it's vital that we look at that as an issue. But one of the things, like Robin said, and you're trying to help this hospital that is in dire need. It was probably 40 years ago when Archibald used a similar process, and it's something I've heard many times talked about. Can you share a little bit about what they did when they assumed the management of those surrounding hospitals around Thomasville?
Yes, ma'am. Although I was not there at that time, it was very successful for those areas. Prior to my tenure with Archibald, we were also in the management of Early Memorial, Mitchell County, Brooks County, and Grady General, which is Grady County. Without that support of Archibald, those areas would have been in the same boat, I would say, as Randolph County. The Archibald system is very well endowed with its money on hand and being able to put resources into those system facilities or affiliate facilities. We're very fortunate that we do get those capital dollars and get to reinvest in our communities, hospitals, because without that, then we become a shell that begins to break. And that's what we have been very fortunate with Archibald, is to reinvest into those facilities to keep them up to speed.
I know, again, it's just because I'm familiar with them and how they work. 3 of those are actually county-owned, county authority hospitals, and Archibald is a private nonprofit. So they had a little bit different twist to them anyway. But I guess I wanted to know the techniques, like what Robin did. What did they do then? And would it work now? I know they centralized certain services, maybe HR. That model won't work today. Is that one of the problems we have?
Yes, ma'am. So a lot of what we did was we took out some of those duplicate resources, as you mentioned, HR, medical records, things that could be housed in one place and then centrally located so that all 4 hospitals could utilize those same resources. So that was very successful. The other piece of it was we utilized the system facilities as feeders to the main hospital. Main hospital would take care of the surgeries, the acute needs, and then push them back out into their communities where they could continue the care until that patient could go home or to a long-term care facility.
Thank you, because I always wondered, why haven't other hospitals done it? Because it does work. And you've each mentioned some of those. And Robin, with what you've done is just monumental. That facility would have been gone, and that is right there in my corner of Southwest Georgia, and we could not afford it to lose it. And I know several of the others have had some type of issues come up, but we do have a few questions, so I'll quit talking and let's see.
Can I make a comment
Sure.
about that, though? What we typically see, though, when I work for the Archbold system. They no longer manage the hospital in Early County. But by the time that they withdrew from that contract, and Archbold's a good organization, he's a friend of mine.
Close friend.
Yeah, Archbold's a good organization, but when you're talking about managing a hospital that is an hour and 15 minutes away from you, the reality is they weren't getting transfers from Early County, so they divested themselves of that organization ultimately. But the bad thing is that while Archbold managed the Early County Hospital, they put nothing into it.
Okay.
And so the hospital, similarly to the one in Randolph County, it got drained of all the life that it had. Who here owns a home and after 25 years hasn't looked at updating your air conditioning system, your electric system, or your plumbing system? You all do it. Okay, you have to do the same thing in a hospital, but when you start doing it, think about a hospital that was built in 1957 and 30, 40 years later, and in 57, we didn't have CAT scans, but you've got fuses, literally fuses in these old hospitals that nobody, an Archbold's not going to do it. A Phoebe isn't going to do it. They're not going to spend the millions of dollars really to upgrade these hospitals. And so what you see over and over again, when you have these management contracts, you see the hospital infrastructure getting old to the point that it needs a $10 or $20 million facelift. I am not a huge proponent of larger systems, no offense to either of you, managing rural hospitals. Quite frankly, they have not been successful. And you can say that some of them are still open today, and that's true. But to the extent that they benefit the parent hospital, that's when they remain open. And then ultimately, even those organizations, you've seen it throughout Georgia, they ultimately get in such disrepair that even the parent hospital pulls away.
Thank you. Chairman Oliver?
I'm asking this based on some history that's distracting me and for the benefit of the public safety chair who's sitting close to me. Several years ago, we passed a super speeder bill that was going to fund trauma. And that trauma funding was going to go for a lot of EMS and helicopters. I'd like to see tell me whether you've seen any evidence that money has gotten to you. And the second question that's kind of related, and y'all can answer it. What are the rules about setting up a ER system? How does that work? Are there any legal barriers to doing that, or is it just financial barriers?
I'll address your trauma question first. Yes, y'all did set up the Georgia Trauma Commission. And in fact, the head of that commission is the head of our trauma department at Atrium Health in Navicent. We are a level 1 system now, maybe only one of 4 in the state. But the money y'all give does go, part goes to EMS, part goes to hospitals and it goes to hospitals for two reasons: uncompensated care related to trauma, and then readiness costs. But for both of those buckets, I think for readiness costs, we get about 7 cents on the dollar of readiness costs to that fund. And I think it's maybe 10 or 12 cents for uncompensated care. So while there's a fund there, it's
How
not an
much does it-
adequate funding source.
How much does it generate the year? And are the counties turning the money over that they get? The
We're
money?
having no problem getting the money. And in fact, now it's coming to us even easier now that y'all passed House Bill 511, so that the money is dedicated to us for at least 5 years. Because originally we thought we were going to have to do a constitutional amendment to get money dedicated. I believe, and I may be wrong on this number, I want to say 23 million last year from Super Speeder, we're very grateful for that, but it's not enough to offset the cost of providing just to open up a level 1 trauma center. You're spending millions of dollars a year just to see your first patient. And I will say trauma on the whole is not one of the worst payer mixes, because you also have auto insurance that can cover some of those costs. So when you look at services, it's not the worst paying, but the readiness costs to be a trauma center, be it a level 1, 2, 3, or 4, is very expensive.
So it is or is not going for ambulance services?
Yes, and I forget, there's a breakdown, a certain percentage that has to go to ambulance services, and it is going to them. I can't speak to how much they get each year. That's just not my area of interest, but yes, my area of expertise, but yes, they are getting that. And we're also getting it from the fireworks excise tax, a little bit from that too. But again, neither one of those sources is an adequate source to fund the true uncompensated care related to trauma in this state. Oh, and I apologize.
Rules about ERs.
So I can speak to our experience in Chatham County with the freestanding ED we just applied for. And to my knowledge, I think this is the first application for a freestanding ED through the CON process in a rural county.
It is a CON
Yes,
process.
it is a CON process. We went through that process. We proved there was a need in Chatham County for emergency services. In other areas of the state, the applications have been for areas where there's already hospitals and there's already emergency care available, because they tend to go in your more wealthy areas where they can make money. I mean, if you're a business owner, you're going where you can make money. So that I will mention also in areas where they have grown without any real regulation, in areas like Texas, insurers there are finding that they are a big abuser of surprise billing, because a patient will show up thinking it's an urgent care center and not realizing they're going to an emergency department, and they'll get hit with that bill as an emergent visit when it was an urgent care. So there needs to be education to the public about the difference between urgent care and freestanding ED.
Representative Burnell.
Thank you, Madam Chair. I just also I don't really understand how this freestanding emergency, how does that work? Because do they send people to the hospital afterwards? I mean, I don't understand that concept.
Yes, ma'am. Just like with ambulatory surgery centers, if you build an ambulatory surgery center, you have to have a transfer agreement with a full standing hospital in case something goes wrong. You can't just go and set up and not have a place to send that patient if something goes wrong. So the freestanding ED would work that same way. But again, it's a solution, I think, for some rural areas where there is no access, but just putting them in areas where there's already access is not necessarily going to help any of our areas increase care.
Is there a difference between, what is the difference between them and like urgent care?
And I'm sorry, if anybody wants to jump in, please feel free to. So a freestanding emergency department provides all the services that you would provide if you walked over to Grady's emergency department. You just don't have that back end of going to an OR or going up to a patient floor right at the same location. Whereas urgent care is basically a doctor's office that is open more hours than a traditional medical office building is.
Let's see, Chairman Collins.
Thank you, Madam Chair. Don't want to go too far down a rabbit hole here, but in talking about certificate of need, that whole process just blows my mind. I'm not a medical expert by any stretch of the means, but I'm just curious. Did anyone object or file any kind of objection to the emergency department?
No one at all objected to
Okay.
that. No, sir.
Okay, that's a
Because
miracle.
there's nobody in that community providing that service now. So there was nobody there to object.
Well, I've
So-
heard horror stories of facilities around the state who have petitioned for certificate of need for expansion of services, and, you know, a healthcare provider in one region that doesn't even touch that region would file objection. And I was just curious. as
Yes,
to
sir. But
see.
y'all actually addressed that
Right.
the last time we passed a CON bill where you put parameters on who can challenge, and now you have to be within 35 miles of that facility.
Yes.
So that cross-state challenge is not allowed anymore,
I
thanks
just,
to what
I
y'all
just wanted
passed.
to ask that
Yeah.
question to make sure that those guardrails were in place, that
Yes,
they
sir.
you did not have that happen.
Yes, sir.
Representative Leverett?
Chairman, Representative Burnout addressed one of the questions I had of really what is the distinction between urgent care and emergency room care? So thank you for that question, Representative. Thank y'all for clarifying that. I think also a question the representative asked, to me, being in a small community, you like having the hospital, but what you really want is some place where they can stabilize your parent when they have some event.
Absolutely. And
Or-
my family's
or-
all from Carrollton, so
Right,
and the
or-
surrounding county, so I
Or
understand.
when
Yes, sir.
someone in the granite quarry has a block drop on their leg and they
Right.
need some kind of emergency
Right.
care to stabilize them for that, or, you know, there's an explosion. And then they can get stabilized and get sent to hospital somewhere else. So I think to Mr. Watley's statement, that's a big deal in a small county because it means a life, you know.
Many years ago, we ran a survey when we were going through some changes and went out to the public to what, you know, if you had to prioritize what you wanted, the emergency room was number one. And it still remains that way.
And I'm curious, Mr. Wally, you said this, that a lot of times I guess there's not even in a small community, there's still not really a financial incentive to setting up that kind of facility. And I wondered, what in your view would provide that incentive? Is it going to take some kind of subsidy or something, or is there some other way around it?
Well, what we're working with Robin on is trying to put the 5-bed hospital along with it. So we'll have kind of the best of both worlds, you know, with some of the reimbursement on the hospital that would subsidize the emergency room. But yeah, it would have to be some change in the reimbursement because, you know, you got some abuse there. You got it in every community where they come in and they shouldn't be there. And we know that how expensive that is, but
You're talking about what is really urgent care walking into an emergency.
correct.
So is reimbursement, though, that's not something we control. That's at the federal level, right?
Part of the issue we've looked at is possibly closing beds and keeping there is issues with Medicare and the way they reimburse, unfortunately, and the way they classify you as a hospital. It really changes your reimbursement level if you don't have those beds open. That's something they are considering, and they've talked about doing, recognizing that not, as you said earlier, the 159, or they said earlier, 159 counties, and everybody thought they had to have a truly functioning hospital where you get all your care. We realize that's not the standard or the way we really should be providing care anymore. But
And
yes,
it's
it's
not
going to take some
sustainable.
changes at Medicare to help with some of that. Yes.
Okay. Thank y'all so much.
Thank you. Representative Maynard?
Thank you, Madam Chair. This question is partly for you, Ms. Julie, as well as a little bit from Stuart, but I've been texting him back and forth. So I know part of the question, he said he can't answer right now. So the counties have this statutory requirement to provide care for indigent and some public health services. And I want Stuart to maybe say what do they have to minimally do? And are they providing that through funding, or does it have to be actual services? And then for you, from a hospital perspective of operating a hospital that may be private or nonprofit, are you receiving money from the counties, or do you know about the minimum statutory requirement? And can you say what that is?
I'm not familiar, like off the top of my head, with the exact requirements. There are public health services that are provided at the county level through the public health departments, like we talked about this morning. And there are, county hospital authorities which can be set up to operate and maintain hospitals within cities and counties. As for what the state requires as the bare minimum that counties have to provide, that's really beyond anything that I've ever looked at before. So I would have to do more research to outline what those legal requirements are.
So we are not-for-profits at Atrium Health, and some of our facilities are true hospital authority, still hospital authority systems. So they were set up by the county. There's a board at the county that runs the hospitals. Others of us are what we called restructured 501c3s. We're still not for profits. I mean, we have to invest everything back into our structure, but it gives us a little more leeway as to how we operate as an entity. But you have to keep in mind, originally, a lot of counties did put money into operating the hospital, because originally all hospitals were not for profit originally. It wasn't until Medicare and Medicaid came along that you could actually make money as a hospital. So traditionally, hospitals have always been not for profit. When they started their hospitals as the hospital authority, the county would put money in, particularly right now in Macon-Bibb and Floyd counties. Macon-Bibb, we used to get about $450,000 a year from the county. We don't get that anymore. There are very few counties in the state of Georgia that still put money towards indigent care. Now, Grantee and DeKalb, of course, being one of the largest. I believe Columbus still puts a fair amount into their hospital over there. But most counties, as they cut budgets, that's one of the first things that they end up cutting is the funding to the hospital. So they used to provide that uncompensated care through the vehicle of the hospital, and then most of them now have just completely cut out that funding for the hospital.
I think a question for the committee that we should think about that can't be answered today is, what are the minimum requirements that the county is statutorily supposed to provide for constituents? Because if we have so many counties without hospitals, does that mean the counties are not meeting their responsibilities?
I'm going to just clarify a little bit that I know.
Okay.
If it's a county authority, it's in the pocket of the county. If it's a county authority hospital, somebody in the county government has responsibility. And I think that's where we've seen so many of the small ones close, because there's not a tax base to support it to the degree that it needs. If it's a private nonprofit or a for-profit hospital, the county is not obligated, unless they go into some kind of contract, to support those. Humanitarily, do they? Yes, a lot of them do, but some don't. Some help with the FQHCs, some don't. So I think it's across the board. I don't know that there is. We'll have Stuart research it, and that's something we will look at as a committee. Is that all your questions?
Yes.
Okay. Representative Brunel?
Thank you. I just wanted to understand, because the county I live in, we have emergency vehicles, ambulances. So are your ambulances tied to your fire department, or do you use outside companies? And do you all have enough fire trucks and all of that? I mean, I'm just trying to understand.
So Miller County, we have the county, the hospital doesn't own or operate today our own ambulances. They are provided by the county, but Miller County Hospital funds quite a bit of that because we need them. And our tax base is very, very small in Miller County. Our hospital receives no tax or any kind of support whatsoever. But because we've been successful, we give back to our county, and that's one of the areas that we do so. We also, however, because of our particular need, we also rely on for-profit ambulance services to provide services to us. Many of our patients travel such a great distance. And by the way, 2 years ago, thank God, just before COVID, we invested in a helicopter system. And so we've got a helicopter right outside our hospital as well. The issue for us is the distance that our patients come from. By the time they have to go by ambulance, and they are coming great distances, and oftentimes taking an ambulance out of Grady and sending it to us, or vice versa, it is difficult. Ambulances just aren't available for those big, stretches of time. So oftentimes we have to go outside our community and engage and hire an ambulance or use a helicopter for a lot of these patients.
Thank you.
That does conclude. Anyone have any additional questions?
Jamie, you got something? Let me make one thing that I think you guys do need to be aware of, and that is we talked a little bit about it during COVID, and we talked a little bit about prior authorizations and the length of time that it can take for a prior authorization. But I just want to bring to your attention something that has gone on during COVID and continues to go on during COVID. And that is that if you've got an individual who is on Medicaid, most of our nursing home residents throughout the state are covered under Medicaid. I'd say probably 95% of them are covered by state Medicaid program. In the Medicaid program, you have something called the Georgia Medical Care Foundation or Alliance, which is a clearinghouse and a prior authorization for admissions. Those organizations screen patients for eligibility for hospitalization based on either interqual, and that's the biggest one, interqual criteria. Many of the patients that we have all seen do not qualify, that have COVID, do not qualify under interqual or Magellan criteria. And so when a nursing home tries to transfer somebody with COVID like his to a hospital, the hospitals simply are denied by the state clearinghouse for that admission. Now, in his case, Archibald, they own their own nursing homes, as do I. But if you are a freestanding nursing home, and I'm not sure about Atrium, but if you are a freestanding nursing home and you have a patient with COVID and they get transferred to a hospital with COVID symptoms and that clearinghouse says, nope, doesn't meet criteria, what do you think is going to happen with that patient? Many times they get shipped back to the nursing homes. And I'm telling you that some of the reasons why we've had deaths in long-term care is because those infected patients were sent back. Quite frankly, not unlike what happened in New York that we all got into an uproar about. But that is still going on today in Georgia. And I think you guys need to be aware of it. I've tried to address it with DC-8, but I haven't been successful doing that. And you can do an appeal, but unless you're a hospital like him or I, those are our patients.
Yeah.
And so we're going to admit them into our Miller County and Calhoun County. Our two nursing homes had no COVID-related deaths in the past 2 years. And the reason is because despite the fact that the state said, no, we're not going to allow the admission into the hospital, we still took them, because we knew what the outcome would have otherwise been. And I know that they would have done the same thing. But if you're a freestanding nursing home with no safety net hospital to go to, that patient's being shipped back to you even today.
So you were uncompensated for those that you kept?
Yes, ma'am.
Okay. Okay, we have another question. Go ahead, Chairman Collins.
What's the reasoning behind that? I mean, can you help me medically to understand why?
Oh, for the life of me, I can't explain that to you. It makes no sense whatsoever. But insurance companies, they talked about it a little bit previously. Insurance companies has a list of criteria. There were doctors in this group earlier today, and they could answer this question probably real strongly. But doctors are the ones who have an MD degree, not me, not you. Well, you might, I don't know. But we certainly don't. But they call it cookbook medicine. So the insurance companies have criteria for what do they think is a legitimate reason for a patient to be hospitalized. And those reasons are outlined in algorithms and something called interqual criteria. And if you don't fit that criteria, it gives the insurance company excuse to say, no, we're not going to pay for that admission. And the state DCH program has adopted the exact same posture. They've had it for years, but who would have ever thought for a disease like COVID that the entire country shut down for, they would have ever applied it to that.
Yeah.
Add to that, to appeal that denial, and eventually sometimes you can get them covered, you end up taking your staff away from treating the patients they need to see to work on the fields. And that goes to all medical necessity decisions, not just
Yes.
this one, but you end up taking staff away from patient care to sit and deal with pills with the insurance company, which is further exacerbating our workforce shortages.
Can I
And
ask a
can tell you,
follow-up?
I never got one overturned. All of our COVID patients that we appealed, the posture was exactly the same. No.
Can I ask a follow-up question? if I
Go right
may?
ahead.
So do you have to report that they have COVID? I mean, if they exhibit other types of illness, if they have a fever, if they're nauseated, you have to disclose to the hospital that you've tested them for COVID. Is that what you're saying?
The hospital is also going to test.
Right.
Yes.
Okay. So once
Yeah.
they get there, the hospital tests and they're rejecting that patient.
And 9 times out of 10, the nursing homes have a real good idea. Well, the nursing homes are actually, the state of Georgia required our nursing homes to swab our patients. So Lord Almighty, yeah, several times a week. So the nursing homes would identify that this was a COVID positive patient and say, oh, got to get him out of here. Let's get him into a nursing home, into a hospital, thanks. And then the hospital would re-swab them and then try and admit them. And then the state would say, no. Now we admitted ours. Because I knew with 100 ventilator patients, do you know what would have happened in my facility? If I allowed them to stay, I would have basically been a mass murderer. And I'm sure he did the exact same thing.
Representative Maynard, you have a question?
For the multi-weekly testing, can you tell me about the cost and the cost with that? And because it's now required by the state, is it a sunshine date on that requirement? And then the third piece is with that mandated multiple weekly testing, is any insurance payer paying for that?
So in the beginning, Georgia set up the Georgia CARES Act, and it went to reimburse for COVID-related expenses. What we had to do was submit weekly invoices to what those supplies were, whether it was PPE, whether it was testing. Some bit of staffing was included if it was the one swabbing. The rule currently is if they are not up to date with their vaccines, which means a 2 vaccine in nearly 99% of all nursing home patients, a 2 booster. If they're not up to date, which means having all 4, then when there's an outbreak, and an outbreak is defined by 1 or more positive resident or positive employee, then we have to test all the residents unvaccinated once a week. We have to test all the staff unvaccinated twice a week, and all the vaccinated staff once a week until we go 14 days without a new positive. Now that the Georgia CARES Act the funding has gone away from that, all of that funding is done by the facility. There is no more support there. When the Georgia CARES Act was involved, we would have to, like I said, we'd submit those invoices, but you take a facility like Glenmore Nursing Home, which is our nursing home in Thomasville, that's part of the Archbold system. part of what we did great with centralizing things and buying them all through the Archibald Medical Center and then dispersing them. Georgia Cares would not allow that type of accounting to go on, and therefore we were not allowed reimbursement for our PPE because we bought it in bulk and then dispersed it. We could show accounting wise through Draffin and Tucker firms, and that this truly went and was used at these facilities, but Georgia Cares Act denied those reimbursements. So all of that funding has gone away now, but we are still required to test. We are still required to utilize PPE. There's still masking mandates in the long-term care facilities and things of that nature, which are not in the hospital sector. So Robin can tell you, there's a little door at Mitchell County that you have to walk through to go into the nursing home, and you don't have to wear a mask on this side, but you have to wear a mask on this side. So it's very frustrating.
Yeah. And so on our hospital side, we still wear masks on the hospital side because the patients come through our doors. But in our nursing home side, it's an N95 and a face shield.
Or goggles.
Yeah, or goggles. And that's still mandated by GCH, actually the CDC, federal government, all those mandates for healthcare are still in effect. All of us are doing it.
I don't see any additional questions, but I do want to thank you. And as you've seen, we're a governmental affairs. We are not a medical committee. So you've opened some eyes and you're seeing some hairs curling. But we really appreciate this information. And our goal here is to serve the people of the state of Georgia. And you've opened our eyes to a lot of things that are going on. And we're very appreciative of everyone that spoke today. Thank you very much. And we are adjourned.
Thank you.